Ladies and gentlemen, the fourth Global Mental Health Summit is starting. Please welcome Mr. Sergio Iavicoli, Director General for Communication and International Affairs at the Italian Ministry of Health.
Honorable Ministers, Excellencies, dear delegates, colleagues and participants from all over the world, I'm pleased and honored to introduce this opening session of the Global Mental Health Summit 2022. A warm welcome especially to all delegates of the 45 countries and 7 international organizations represented here, the civil society and scientific community, and the people with lived experiences. The Italian Ministry of Health, in collaboration with the Italian National Institute of Health, is glad to welcome you all to this 4th edition of the Global Mental Health Summit that follows the previous ones held in London, Amsterdam and Paris. I take the opportunity to thank the WHO, the previous organizers, and all the other organizations represented in the steering committee that I had the privilege to chair with Fabrizio Starascia, who actively contributed to the planning and organization of the summit. This edition's main focus is on advancing community-focused approach to mental health for several reasons, as we will hear. One of these is because Italy was the first country to deinstitutionalize the mental health care by closing the mental hospitals starting from 1978. And this has been achieved particularly thanks to the visionary work of Franco Basaglia, a true pioneer in the field, well known at international level too. 1978 was a very special year for Italy. It is in fact the year where the National Health Service was established. A lot of work and efforts have been done, but still there is a lot to do altogether. Now, with a view also of sharing our heritage and experience, I'm pleased to introduce a short video entitled Open Minds and Open Door, that has been specifically realized and produced by RAI, our national public broadcasting company, with the collaboration with experts from the National Health Institute and the Ministry, that I thank for their precious work and passion.
In Italia è il movimento della psichiatria alternativa. Inizia nel 60.
The movement starts in 1960 when Franco Basaglia had the management of this workshop in Gorizia. Even personally, many Italians paying the responsibility of this choice have to face the dramatic reality of segregation. I can't propose anything psychiatric in a traditional asylum. In a hospital where the patients are tied up, I believe there is no therapy of any kind, biological or psychological therapy, that can help these people that are forced in a condition of subjection and captivity by those who have to care them. What does it mean, hospitals locked down? Locked down? A prison. Have you ever known hospitals locked down? Yes. What experiences have you had? They tied me up. They beat me. They wanted to give me the electroshock treatment. I was terribly scared. Do you believe that people outside want you to be in a lockdown or normal hospital? Look, I don't care about the people outside. I'm interested in taking care of my future. If you think you want to know something more, look, the sun is out of there. I'm alone. Do you want me to sing you a song? O Sole Mio or Mama? Do you want me to make you cry? Do you know what it's like to be alone in life? Sing, sing if you have courage. The patient who leaves the hospital is not left to himself. For those who cannot find an accommodation outside, life goes on inside the hospital. The thinning out made available some pavilions, and some apartments have been created for the discharged patients. In the confused but also full of initiatives landscape of the psychiatric care, Turin offers new examples. This is the case of the new cooperative, trying to deal and overcome the marginalization, giving its members a salary, 450,000 Italian lira per month. After the opening of the asylums, I want to live in a group home in the Ottavia district of Rome. I like to paint and write. My name is Nicola Fanizzi. I'm 48 years old. I come from a certain environment. Santa Maria della Pietà. I come from the asylum. But since I've been discharged and I live in a group home with 2 other former patients from the Santa Maria della Pietà asylum, many things have changed. What is your favorite recipe? There are plenty. It could be pasta with radicchio, radish and salmon. It could be anything like a good meatloaf. Ferdinando is 30 years old and lives in a therapeutic community. During the day, he attends a course of pre-training for assistant cook. I do a course of treatment. So I take therapy. That helps me to become stable. It helps me to maintain a base so you can work on it. So I rediscovered what my qualities are, the path that leads to be a better person in a better world. The community to fight loneliness, because the psychiatric distress is like in any other structures. During the pandemic, had to find out new ideas and new inspirations to make the guests interact with the environment and with each other. This allowed us to bring out unexpected resources. It was a job opportunity. We hope that soon we will be able to invest again on the outside and continues to work to reach our goals. I found my family and all the affection that my parents did not give me. I was taking a list of 3 pages of medicine. I did the drug scaling. Thanks to this scaling drugs, I can work in the cooperative. I feel an accomplished person. My life is a dream. I found the love of my life was Michele. In the long run, many goals have been achieved, but many are still to be achieved. Italian poetess formerly hospitalized, Alda Merini. In my diary, I tell the day that the Basagliolo opened the gates for us, and we could touch the roses. We ate them. We were hungry for meadows and freedom.
With these words of the poetess Alda Merini in our mind, we now move to the opening addresses, and I'm pleased to leave the floor to our Minister of Health, Roberto Speranza.
Dear colleagues, excellencies, ladies and gentlemen, welcome in Roma and welcome in Hospital Santo Spirito. This used to be an hospital, and this is the oldest hospital of Europe. It's a great pleasure and honor for me to welcome you all here and to say hello even to everyone who is connected by live stream. This is the 4th Global Mental Health Summit, and we have 52 delegations coming from everywhere in the world. I would like to thank Dr. Tedros, Director General of WHO, and the European Commissioners Stella Kyriakides for their support to this summit. Mental health is much more than about the absence of disease. It is an intrinsic part of our individual and collective health and well-being. It is an essential component of the resilience of communities, and it is therefore essential to implement national policies that promote inclusive, effective mental health systems and in protection of rights by developing community-based mental health services capable of achieving universal health coverage for mental health. Our society must be free of and strongly oppose any kind of stigma and discrimination, where mental health conditions are protected and prevented, and where mental health is promoted, and where people with any form or mental health condition can exercise their human rights, can live with dignity, and can have the access to affordable mental health care, improving the quality and safety of services for the benefit of patients and health professionals. In order to achieve this, a concerted effort of all countries is necessary, whether they are of low, middle or high income. There is a need to overcome certain barriers, among others, lack of funding and investing in mental health care and research, scarcity of skilled human resources, societal stigma and discrimination. Thus, the Global Mental Health Summit will be instrumental in highlighting the different capacity building strategies of countries, such as the identification and sharing of information and good practice, including the new opportunities provided by the digital mental health and other alternative or innovative initiatives developed during the recent pandemic. The global mental health can also make a significant contribution in research, epidemiology and data sharing. Identifying common interests is the easiest way to not get stuck on the different positions. There is no health and there is no well-being without mental health. 44 years have passed since 1978, when in Italy the Basaglia law was adopted, based on the discovery of rights as a key tool in mental health care. It has changed the organization of psychiatric care with the aim of shifting the heart of care from psychiatric beds to communities. This approach has led to the decline of custodial methods, recognizing instead the need to care for the people within their community and strengthening community mental health care services, implementing the active participation of people in process of care and promoting dialogue with civil society. The fundamental meaning of the Basaglia law, in addition to restoring dignity to the psychiatric patient, is in fact putting people at the center. Thus, Italy has become an international reference model for its decision to implement a network of community services for mental health. Anyhow, there are still some critical issues in relation to the treatments provided that still need improvements. The uniqueness of the Italian organization requires an additional effort to grasp its peculiar aspects, both to underline its highly innovative elements, but without being afraid of identifying its criticals with a view to continuous improvement in order to rethink future policies, also in light of vulnerabilities that emerged in course of the pandemic, enhancing the attempts made so far that have emphasized the role of good practice, geographically and sometimes historically circumscribed, and taking community mental health as a reference frame. The main object of the Global Mental Health Summit is to strengthen the global action by governments, international organizations and civil society which have an important role, and to address the key issues related to mental health care, which have been opened under the pressure of the recent health and humanitarian crisis, overcoming the structural weakness that prevent millions of people from receiving adequate care for their mental health needs. We are grateful to WHO that, as a global leader on health, has put forward many initiatives to achieve the global objectives set out in the WHO Comprehensive Mental Health Action Plan 2013-2030 and the Sustainable Development Goals. Last but not least, the publication of the World Mental Health Report, Transforming Mental Health for All, that is designed to inspire and inform better mental health for everyone, everywhere. On June 2021, the second National Conference on Mental Health in Italy was held to reaffirm my personal commitment and that of the Ministry to promote and relaunch territorial assistance for mental health at home, to make the community as a frame of reference to protect human rights and dignity of people with mental health conditions, to encourage inclusive and participatory care wherever possible, to improve the quality of safety of services for the benefit of patients and operators, because no one can be left alone. The main topics of this fourth Global Mental Health Summit are the central role of a community-focused approach to mental health and the involvement of people with lived experience and their families in the process of care and recovery, which are convinced within a framework that emphasizes the importance of human rights and the dignity of people with mental disorders. Mental health is a crucial issue, and this is why, in the last year, I wanted the G20 Ministers of Health to be open with an event on mental health, in order to give a strong signal that is absolutely crucial for the policies of the coming years to take an important step of common convergence on the action to be taken for a holistic approach to the challenge to be faced. The COVID-19 pandemic had a major impact not only on health systems and services exposing their fragilities, but it also had a major impact on mental health, though some mental health conditions have increased by 25% compared to the period before the outbreaks of COVID pandemic, further increasing in numbers the nearly 1 billion people already living with mental health disorder. The war in Ukraine, with its thousands of victims and millions of refugees, is having a terrible impact on mental health in that country, while in our societies is increasing anxiety and stress related to the economic uncertainty and the cost of living. Those mental health should be regarded as an essential component in preparedness and response to emergencies such as those we are currently facing. Mental health is also an essential component of crisis response and economic recovery efforts. Therefore, the implementation of national policies promoting inclusive, rights-based and effective mental health system is even more necessary. I wish to all participants in this fourth Global Mental Health Summit a successful and fruitful work, because the result that we will achieve together will be the basis to continue the common work and commitment, making us more united and more competent, and most of all, to leave to future generations fertile grounds on which to make human rights grow firm. Thank you very much.
Thank you, Minister Speranza. We are now honored to display a special video message of the First Lady of Ukraine, Ms. Olena Zelenska.
Саміту. Дякую за надану можливість звернутися до шановної аудиторії та розповісти, як Україна в умовах війни розбудовує систему відновлення та збереження психічного здоров'я. Але спочатку я хочу навести кілька прикладів, які пояснять вам, із чим ми зіштовхнулися. Уявіть родину. Хлопчик із відчимом йшли по окупованому росіянами селищу, що на Сумщині, коли на них свідомо наїхав російський танк. Відчим загинув. Хлопчик втратив ногу. Або літнє подружжя, яке пережило бої на своїй вулиці на Харківщині. Їхній будинок повністю зруйновано. Вони втратили все, що нажили. А вже на мирній території в чоловіка знайшли онкологію. Тепер родина живе в палаті місцевого онкоцентру, бо більше їм немає де жити. У іншого хлопчика в окупації в місті Маріуполь загинули мама і тато, потім бабуся і дідусь. Хлопчик голодував у підвалах. На щастя, він знайшов нову родину. Але його нові батьки, такі само вимушені переселенці, кажуть, що хлопчик не одразу почав розмовляти. І ще одна історія. Військовий полонений з Азовсталі після полону в Росії втратив 30% ваги. В його руці не вистачає тепер 4 сантиметрів. Кістки, бо вона була зламана і її весь цей час не лікували. Все це реальні і страшні історії травм. Не тільки фізичних. А й найперше – душевних. Як жити всім цим людям, які пережили те, про що я розповідаю? І найгірше, що це лише деякі історії. Бо в кожного з мільйонів українців своя травматична історія війни. Діти, які втратили батьків, батьки, які втратили дітей, люди після тортур, після окупації, люди, які втратили дім та нормальне життя, які більше не можуть чути гучних звуків. Ось так тепер можна було б загалом охарактеризувати українців. Але це зовсім не так. Ми оговтуємося. Нас підтримує травми, які стоїть перед суспільством і системою. В ООС та інших міжнародних партнерів. І в той же час цей наш задум та рецепту тут немає. Ми маємо створити його самі. Тож зараз ми, як пазл, збираємо нашу програму допомоги. Наші фахівці вже отримують найкращі практики у колег з Ізраїлю, Бельгії та США. Ми відкриті до
Zelenska. And now the video message of the Director General of the
as rates of depression and anxiety shot up. Despite this, most countries continue to allocate very little funding to mental health. In some countries, the treatment gap for severe mental health conditions without mental health
falling into social exclusion, by promoting their psychosocial well-being, and by using team sport as a way of giving them better social skills. We have also focused on those most vulnerable, those fleeing war and persecution, and mobilized funding to help people fleeing Ukraine in urgent need of mental health and trauma support. Friends, this year, World Mental Health Day focuses on mental health and well-being for all as a global priority. To achieve this, we require action from governments, international organizations, and civil society. With its focus on learning lessons and taking action, this global summit will help make that happen. And with our shared vision of mental health as a priority, together we can keep mental health issues in the spotlight. I wish you a successful summit. Thank you.
Thank you, Commissioner Kyriakides. And I now would like to invite on stage Honorable Marina Sereni, Vice Minister for Foreign Affairs and International Cooperation. Vice Minister Sereni, the floor is yours.
Thank you very much. Excellencies, addressing the issue of mental health at the political level is key to accelerate transformative changes, knowing, as WHO Director General just said, there is no health without mental health. Italy has a traditional engagement on this issue at the national and international level. While the colleagues of the Ministry of Health will elaborate more on the national dimension, I wish to highlight that the Italian commitment at the global level has been in the recent years confirmed by the support to progressive language on mental health within the political declaration on non-communicable diseases in 2018. I am glad that Italy is hosting the 4th edition of the Global Mental Health Summit, taking the baton from the United Kingdom, the Netherlands, and France on a crucial issue. Last October 10, the World Mental Health Day reminded us the dramatic situation described by the World Mental Health Report. Mental health conditions are increasing worldwide and can have a significant effect on all areas of life. About 1 in 8 people in the world live with a mental disorder. Anxiety and depressive disorders rose more than 25% during the first year of the pandemic, adding to the nearly 1 billion people who were already living with a mental disorder. Many vulnerable groups of the population, for example, adolescents, have shown an increase in risky behavior, such as suicide attempts and substance abuse, especially due to the COVID-19 pandemic, as well as protracted conflicts and protracted humanitarian crises. Around 20% of the world's children and adolescents have a mental health condition, with substance abuse increasing this burden. Despite these figures, mental health remains underfunded, with less than 2% on average of countries' health care budgets. With the pandemic, mental health services have been severely disrupted, and the treatment gap for mental health conditions has widened. Scarce resources, overburdened health system, essential health workers under extreme pressure, lockdowns preventing access to treatments and adequate follow-up create a perfect storm for psychological support. In many countries, there is a lack of quality and comprehensive services at the community-based, though they could prevent mental disorders, ensure access to care, reduce stigma, and promote social inclusion. Services are often not yet fully integrated into primary care and hospitals. Therefore, accessibility is very limited, and not all patients with mental health problems are recognized and treated. Systems often lack specialized care for women, children, adolescents, and the elderly. Experience on the ground also shows the need for rehabilitation programs to help patients develop emotional, social, and intellectual skills necessary to live, work, and grow in their own community. The Italian cooperation is focusing on the development of policies, on the provision of services, and on the involvement of communities, on the decentralization of services by directing resources towards community intervention, and on strengthening the capacity of health professionals. To this regard, I wish to remember the cooperation with the Trieste local hospital in the Palestinian territories and the prevention and treatment from alcohol and other substance abuse in Bolivia. Furthermore, in almost all the humanitarian intervention financed by the Italian cooperation in partnership with civil society organizations and international organizations, psychosocial support is foreseen, considering that refugees, internally displaced people, returnees, and vulnerable host communities have been exposed to significant levels of violence, both physical and psychological. In 2022, Italy has also doubled its funding to the WHO program Health and Migrants, that also aims at addressing mental health of people on the move. Much more needs to be done in perspective in terms of policies, funding, training. Italy will continue its engagement on mental health to ensure that no one is left behind. Thank you very much, and I wish you a successful meeting.
Thank you, Honorable Sereni. I now am pleased to leave the floor to President Mauro Palma, who is the national guarantor of the rights of the person deprived of the liberty in Italy. Please, the floor is yours.
Good morning to everyone, Minister, Excellencies, distinguished participants. Thank you very much for inviting the national authority as a national preventive mechanism that is an independent monitoring body operational in 2016 and has a mandate on all places of deprivation of liberty to control any condition of people and also any compulsory treatment in order even to protect Italy from the possibility of any violation of Article 3 of the European Convention on Human Rights. In its oversight activity, the national guarantor has observed that there is still a difficulty in interpreting any psychic distress within the socio-relational context in which it develops and to which such a disease shall inevitably be connected, certainly not in order to deny it, but rather to build possible pathways to cope with it. The starting point is the principle that exclusion is never a solution, since any psychic distress calls for a tight and lasting connection with the community at large, also understood as therapeutic, environmental, and relational. It requires customization, punctual analysis, and contextualization of its origin, its development, and future. It entails resources and continuity of intervention from the targeted professionals. There is still room for improvement in this area. In the opinion of the national guarantor, The analysis should again be extended to how today any behavior that cannot be ascribed to parameters of an assumed normality in our current context is addressed, and of how psychic distress is also dealt with in the community. It is important to stress again the teaching and the experience that led to the Italian law now more than 40 years ago. And not only it was a way to introduce a possible change in the medical approach to mental health issues and how to deal with them, but also a change in the social and then widespread culture in our community. Now I know it's time of difficulty. Too often, the very ideology of diversity risks bouncing back as a topic of a reference. Now, again, there is a tendency to resolve any difficulty, in particular in places of deprivation of liberty, in prison, as something that put question to the psychiatric diseases. This is a way to enlarge and enlarge the difficulty, enlarge and enlarge the request of psychiatric support, and it is also a way not to interpret in a correct way what that situation requires. Now it's urgent to come back to the principle that in this country were the main principle more than 40 years ago, and to keep those principles as a value that was also extended since that moment, in a moment of very difficult for our country. 13 of May 1978 is the date of the law, 4 days after a tragic event in our country, 4 days after founding the Aldo Moro killed in our country. We had the capacity to go ahead, to go on and approving this fundamental law. This is a stress that I would like to stress this issue, because I think that is important for us, for a new legislature that is coming today, and also for the other countries. And this is my wish for this global summit, that we continue considering that it is a fundamental value for our community at large. Thank you very much.
Thank you, President Palma. Now I'm very pleased to give the floor to Professor Franco Locatelli, our President of the National Health Council.
Dear ministers, dear excellencies, distinguished colleagues, good morning to everybody, and let me express my profound gratitude for being here today in Rome for attending the 4th edition of the Global Mental Health Summit. It's a great pleasure and an honor for me to welcome you and to wish a very fruitful and productive meeting. In these 2 working days, we will have the opportunities, I would say the unique opportunity, to address many important issues related to the mental health. And there is no need to further emphasize how the COVID-19 pandemic and the more recent crisis have clearly revealed the importance to invest on the mental health. There is no global health without a protection of the mental health. And we need to find innovative solutions for rendering the approach for protecting the mental health standardized and homogeneous worldwide. I am a pediatrician, and let me spend just a couple of words to emphasize the importance to invest on the mental health of children and adolescents. We must protect them. They represent our future. I am so glad to see that in the program there will be a session specifically dedicated to children and adolescents, exactly for the reason that I mentioned a few seconds ago. I don't want to speak any longer for not subtracting time for the scientific presentations and the discussion. Just let me thank the organizers that have arrange everything in a beautiful venue for rendering this fourth edition of the Global Mental Health Summit an unforgettable event. In particular, I'd like to acknowledge the great work done by my colleague at the High Council of Health, Professor Starace, the great work done by Dr. Iavicoli, Dr. La Cecilia, and all the other people, including Dr. Leonardi. So I really wish a very productive and fruitful meeting, and I am sure that at the end of these 2 days, we will have clearer ideas on how to protect the mental health and, more importantly, clear strategies and policy to protect the mental health. Have a very productive meeting. Thank you.
Thank you for your words, Professor Locatelli. We now move to the last presentation of this opening session. So I give the floor to Dr. Fabrizio Starace, who will introduce briefly the program outline.
Good morning. Welcome to everybody. Honorable ministers, Your Excellencies, distinguished delegates. The Global Mental Health Summit opening today is meant to be an opportunity to rethink the ways to support persons with psychological distress or mental illness, dealing with the multiple crises we are confronted, recognizing the needs of the most affected by adverse experiences and risky environments, increasing human rights of people who are suffering mental illness. Above all, changing our perspective and going towards adequately funded and staffed mental health services in the community, for the community, with the community. Community mental health is at the core of the keynote speech and of first panel this morning. Promoting mental health through activities and interventions performed in the community rather than institutional settings is based on the evidence that mental health is deeply influenced by the context where people live, that communities would be best establish the mental health facilities that fit their unique needs, and that care should be provided where it is easily assessed as people get on with their lives. What does an optimal mix of mental health service look like? What needs to happen for countries to make this a reality? What does the implementation of effective community-based services look like around the world? These are, among the others, the questions panelists will answer. The barriers to finding, accessing, and affording mental health services are especially devastating to the most vulnerable, who face already critical circumstances that challenge their mental health and psychological well-being. Who they are? People on the move, women and children, people with disabilities, elderly, indigenous communities. These are among some of the most vulnerable, to whom the need may be bigger, but the availability shorter. The second panel will provide knowledge and experience-based insights to get a better integration of mental health support to people in vulnerable situations within collective strategies of response to emergencies. As Anby said before, health, including mental health, is a human right. But despite widespread adoption of human rights instruments such as the United Nations Convention on Rights of Persons with Disabilities, including psychosocial disabilities, people with mental health conditions continue to be subject to widespread human rights violations due to stigma, discrimination, and so on. It's time to reverse course, advocating for concrete actions, translating into practice principles and recommendations, ensuring that these rights do not remain only on papers. By sharing lessons from their experience, the speakers of the third panel will offer leaders across the world examples of what can be feasibly implemented and challenges in doing so. Let me conclude by acknowledging the presence here of more than a few persons with lived experience who will actively contribute to the debate. We consider empowering patients at the basis of the necessary change. The lively, decisional involvement of users' representatives in all contexts where policies are discussed, implemented, and evaluated is essential. On behalf of the steering committee of the summit, my grateful thanks to all of you. Thank you.
Thank you, Fabrizio. And now, before closing this opening session, we have a short video which is in collaboration. As you know, WHO is a strong partner of this event, and particularly I would like to thank the Department of Mental Health and the Department of Communication has been always very close to us. So we have some global figures to highlight the first word of this summit, global. We really intend a shared problem that are all over the world, and they are really global and common, and they don't belong only to Western countries. And we really, with this message, we would like to show some global figures.
All of us, at some point in our lives, are affected by mental health problems. We might have mental health problems ourselves, or know someone who does. Conditions range from the most common, like depression and anxiety, or problems with alcohol or drugs, to bipolar disorder or schizophrenia. It is well known that poor mental health contributes to physical health and social problems. It also results in economic loss for individuals, families, and communities. And people who experience mental health problems are often socially isolated or at high risk of human rights violations. Yet, even though poor mental health has serious consequences for all societies, it remains one of the most neglected areas of global efforts to improve health. 1 in 8 people live with mental health condition. Nearly 1 billion people have a mental disorder.
Depression haunts and hurts 150 million people. 14% of the world's adolescents lived with a mental disorder in 2019.
Almost 3,000 people commit suicide every day. 1 out of 100 deaths are suicide. Mental disorders are the leading cause of years lived with disability. People with severe mental health conditions die on average 10 to 20 years earlier than the general population. In low-income countries, there are fewer than 1 mental health worker per 100,000 population. On average, countries dedicate less than 2% of their healthcare budgets to mental health. Psychiatric hospitals absorb 66% of national mental health budgets.
With this, I thank you all, and I call Professor Silvio Brusafero, President of the Italian National Institute of Health, to chair the keynote opening session.
Dear Ministers, Excellencies, distinguished delegate, dear colleagues, let me say first of all good morning to all of you and welcome in this historical building that reminds us as the community took care from each other right in the past, many centuries ago. And this is, I think, besides the beauty of the location, tell us continuously that we have an heritage to continue for the future generation. And I think that this event can be a good opportunity to share our experience and to go further in terms of translating and sharing knowledges for the present and for the future generation. As the President of Italian National Institute of Health, I'm really honored that the Minister and the organizations and Dr. Starace, Professor Starace, and Dr. Javicoli asked me to moderate the first session. And so I'm really happy also that the title of the session focus on the term of community, because community has a key role in terms of prevention and of mental health, of course, but also in promoting mental well-being. As you probably know, Italian National Institute of Health is the scientific and technical body of the national health system, meaning that all the different articulations of the system we are engaged with. And our researchers at national, international, and regional level are actively engaged in trying to study, monitoring, together with other colleagues in Italy, in the regional systems, and around the world, the monitoring and studying the mental health and the mental well-being. But with specific point of view, that is the attention to public health issues. So looking at mental health, studying, researching on that, but putting the research, putting the monitoring within a public health perspective. And in this perspective, I'm really happy, honored, to give the floor to the first speaker, the first keynote speaker, that is Dr. Rabi El-Shamai. He is a psychiatrist with a long experience in Lebanon. Is responsible for, is head of the mental health program within the Ministry of Health of Lebanon. Work on this topic for many years, at least 5 years, and not just leading the program and guaranteeing, even during the pandemic, a special attention, a special program to fight, of course, the virus pandemic, but at the same time to fight the effect on mental health and mental well-being of the virus and the pandemic. So thank you very much, Dr. Al-Shamai, for being with us and for sharing with us your precious experience. The floor is yours.
Thank you. Excellencies, colleagues, this would have been unthinkable 25 years ago. Having such a high-level meeting with such a high and wide representation to discuss advancing community-based mental health. Having this meeting in Italy, the very first country that transformed its system, is the best setting for such a discussion. I want to take this opportunity to express my appreciation and gratitude to the government of Italy for hosting this event. Grazie mille per la sua ospitalità. The path that led us here hasn't been easy. We stand here on the shoulders of pioneers, men and women who dedicated their lives and their careers to open the way and pave it with their relentless work. Some of them are here with us today. I invite you to join me in expressing a deeply felt sense of gratitude for them and their work. As shown by the WHO World Mental Health Report 2022, Transforming Mental Health for All, the progress is undeniable, be it on the level of countries that updated their mental health policy, the research, the advocacy, the availability of evidence-based intervention. However, this progress falls short of what should have been done by now. The figures from the same report, as we've seen, are alarming. If we look at the mental health global case, we can't but be stunned by the discrepancy between the urgency to act and the little political commitment at all levels to address this matter with the seriousness and the investment it merits. We speak about mental health as being the silent pandemic or the next pandemic after COVID, and I can't agree more. We're still dealing with the huge impact of COVID pandemic on people's mental health. But as a global community, we were able to unite and work together to address the COVID pandemic, showing how catalytical a high-level political commitment can be to create synergies, mobilize resources, and find solutions. Yet, I can't help but wonder why. Why haven't we yet been able to move with the same commitment and pace on the silent pandemic that we have at our hands in relation to mental health? Excellencies, colleagues, my personal goal in addressing you today on this topic is not to convince you. I believe that your presence here speaks tons to where you stand regarding the importance of acting on mental health. And as someone working at the intersection between policy development and implementation, as someone in a similar position to some of you, and as someone who witnesses the complexity that ministers and other officials and ministries have to deal with on a daily basis, I want to start by saying, I understand. I fully understand how difficult, complex, and may I say, unfair of a situation we might find ourselves in, having to prioritize between all the different files. Yet I wonder why we're not able to be convincing to others, whether other ministries, heads of governments, heads of states, or donors. Would the argument from the economic side help? Would $1 trillion of annual losses of productivity and growth due to depression and anxiety alone help? Would the obvious return on investment for mental health that can be $4 for each dollar spent convince? It should, yet it does not seem to be effective in helping us advance. Colleagues, friends, from the same trenches you're in, I'd like to share with you what I've learned about reforming mental health systems. I come from a country with a long history of civil war, a country that is the host for more than 1.5 million refugees, with the highest capita of refugees, 1 in 4 persons living in Lebanon is a Syrian displaced. A country that on top of the COVID pandemic has been dealing with a political deadlock, an economic crisis, a country that experienced the third biggest non-nuclear explosion in the history in 2020. During the last 2 years, I have been asked if working on reforming the mental health system is the best thing to do to help people and to help their mental health. And I've been asked if it wouldn't be more effective to be engaged in other domains, specifically in Lebanon, politics or economy. And I think this is a legitimate question that many of us might face, with countries having more problems and more needs. However, taking a closer look, one realizes that in such circumstances, more people are at risk of developing mental disorders, and more people will need services. A depressed person, parent, unable to find a job or take care of the household, an anxious student not being able to attend school, or a person with a severe mental disorder who relapsed because the family can't afford the medication. All of them and their families will be better off if they have access to community-based mental health services. And I would argue that they would be able to take action on the circumstances that got them depressed or anxious or relapsing in the first place. So the first lesson I learned from my work in Lebanon, no matter what the causes of suffering of persons in your country, no matter what are the crises that you might be facing, investing in mental health will contribute to lessening the suffering of people and will empower them to cope with and change the situations they live in. Let's say by now you were able to convince the people you need to convince that investing in reforming the mental health system is the right and smart thing to do. Or let's say you are the Minister of Health and you are convinced that investing in reforming the mental health system is the right and smart thing to do. If you're from a low and middle income country, you're very likely to either, one, not have funding for mental health to start, two, be in a humanitarian crisis, and in several cases, it can be even both. Then the question becomes how to start. Well, no one way would suit all settings and countries, but we know from different countries by now that crises often can be a catalyst to reforming mental health system. The 2013 Building Back Better report from WHO is an excellent resource to read on that matter. In Lebanon, this is precisely how the mental health reform started. Building on the humanitarian response to the Syrian crisis in 2013, the Ministry of Health chose a long-term vision, established the National Mental Health Program with the support of WHO, UNICEF, and IMC, and developed the first national mental health strategy to reform the mental health system with the vision that all people living in Lebanon will have the opportunity to enjoy the best possible mental health and well-being. Funding has been and still is a big challenge to sustain this program and to continue the reform. Most of the staff in the program are project-based through our partners, and very few donors, namely the French Agency for Development, decided to provide partial institutional support to the program. Yet, after 8 years of work, we still don't have any sustained support for the team by the end of next year. Funding is and will always be a problem for you too. But there's no need to have all the funds for the reform to start. Starting will generate interest and funding for your reform. If you look closer, there's likely some funding coming to your country from mental health, or some already existing within your system that you can allocate differently. In addition, there is more appetite now within government and within the donor community to support countries, especially when they see the leadership and the vision the country has for mental health. This brings me to the second lesson I learned. Money is not as big an obstacle as you might imagine, or at least it's not your biggest challenge. Starting will generate the resources that you need. What is most needed is not money. What is most needed is your leadership. The rest will come. And once you've given mental health priority, the first thing you should do is enable and support the technical unit or the focal point that you might have or that you might identify to coordinate the planning and the implementation of the national roadmap for mental health. Having a well-resourced unit that is technically capable and that has the mandate to govern and convene all actors around one table will be the most crucial piece of the puzzle. And here I would like to raise a call for international mental health funders. Please reconsider how you've been funding mental health so far. In addition to the specific short project that might interest you, have multi-year funding, and support system strengthening, support institutions long enough for them to be able to take over. Support ministries of health establish and develop a competent, well-resourced mental health unit. It will be one of the best investments you'll ever make. Excellencies, colleagues, by now you have the convincing arguments and the needed initial resources to start. What's next? What exactly to start on? How to prioritize? We don't have to reinvent the wheel. WHO's comprehensive global action plan for mental health, endorsed by you, gives a solid blueprint that countries can use, from governance, leadership to service development, prevention and promotion, monitoring and evaluation, and evidence generation. All these domains are critical and create synergies with each other. The special initiative for mental health that WHO launched to help countries have a comprehensive, tailored approach to developing their mental health system is a good framework to learn from. It helps countries identify their priorities and get the ball rolling. I strongly encourage you to speak with fellow delegates present with us here today from countries that have joined this initiative. You're going to learn about it, I think, later on in the conference. Now, if you allow me, I would like to zoom in on the services as they are the conference focus. And I'd like to start by sharing WHO definition of community-based mental health care, just to make sure we're all talking about the same thing. Community-based mental health care includes any mental health care provided outside of a psychiatric hospital. This includes services available through primary care, specific health programs, general hospitals, and relevant social services. It includes various community mental health services such as community mental health centers and teams, psychosocial rehabilitation program, and small-scale residential facilities, among others. As you see, developing community-based mental health services means creating a network of services at different levels of care, providing various interventions that vary in intensity and in specialization. No one type of services will be enough. We know that integrating mental health into primary care is a huge step forward, but it should not and cannot replace the secondary level of care, where mental health professionals receive complex cases referred by the primary care and provide support and supervision for them. In fact, this level of care is the cornerstone of community-based mental health services. Mental hospitals are not part of community-based services. Mental hospitals or psychiatric hospitals are specialized facilities that provide inpatient care and long-stay residential services for people with severe mental disorder as defined by WHO. In most cases, people who otherwise are fully able to live in the community if appropriate services exist, spends decades of their lives locked up, deprived of their freedom, and subjected to the worst treatment that can amount sometimes to torture. Despite the best intentions of the people running these institutions and the best intentions of the healthcare providers working in them, it's time to admit that psychiatric hospitals simply don't work, and that it is time to replace them with community-based mental health services. It is time to seriously work towards deinstitutionalization. And while we work in parallel on scaling up community-based mental health services and scaling down and potentially closing those facilities, we must ensure that people in these mental hospitals have the best possible care and that their human rights are respected. WHO Quality Right is an excellent tool to help with that. My third and last lesson that I would like to share with you: when it comes to services, have a comprehensive vision of where you're heading in terms of scaling up community-based mental health services and scaling down and potentially closing psychiatric hospital. And while you're at it, make sure that the persons in these institutions have decent living conditions and are receiving the best possible care that respects their human rights. Excellencies, colleagues, I know that this might come as an oversimplification of the challenges that you are facing. It is not meant to be so, and it's not meant to be a recipe either. It's merely sharing my journey and what I've learned so far. I'll sum it up in 3 simple sentences. 1, investing in mental health is pertinent no matter how many difficult challenges a country might be facing. 2, money is not your most significant obstacle. Your leadership is what is most needed. 3, plan your services from the get-go with deinstitutionalization in mind and establish a well-resourced mental health unit at your ministry. It will be one of the best investments you'll make. Since our day started, we have lost around 250 persons to suicide. These losses could have been prevented. Countless more live in unacceptable, inhumane conditions. Millions are unable to access acceptable, effective, community-based services. Excellencies, colleagues, friends, our inaction as societies and as member states on mental health will be one of the most poignant stories of our moral failure as humanity that history will register and that future generations will hold us accountable for. And I know that none of us would want to look back and say that there was something that I could have done, but I didn't. It does not matter if it is difficult or if it is complex, if it is the right thing to do. Mental health is not an abstract notion in our heads. The suffering of so many is the best proof of this reality. Just because we can't see it, it does not mean it's not real. With 1 in 4 people experiencing a mental health condition in their lives, it means that it will be either me or one of the 3 people that I love most who will experience a mental disorder. So today, during our working sessions, discussions, and the decisions we'll make to move forward the needle on mental health, in addition to the thousands and millions for whom we are accountable, Let's have present in our minds the faces of these three persons that are dearest to our heart. And imagine what mental health systems and what services would like to have available for them and for us. Thank you.
Thank you very much, Dr. El Shamai, for this comprehensive but also inspiring lecture. And also thank you very much for giving us a very precise to-do list that will be, I think, the best starting of this Global Mental Health Summit, because we hope that by the end of these 2 days, that this list will be declined in more precise point, and giving this to-do list is very much important for us. So thank you very much, and I think we have a break at the moment, and so you are invited for the coffee break in the back of this room.
Ladies and gentlemen, enjoy the break. Coffee is served in the Balivi room until 11 o'clock. Thank you. Ladies and gentlemen, next session will start shortly. Please take your seats. Speakers are invited to join the stage. Thank you. Ladies and gentlemen, next session will start shortly. Please take your seats. Speakers are invited to join the stage. Thank you. Ladies and gentlemen, please welcome Mrs. Deb, Director of Department of Mental Health and Substance Use at the World Health Organization.
Good morning. Do you hear me well? To all those that are in the back enjoying their coffees and sweets and desserts, it's time to go back to work. So please, join us. A tutti quelli che sono seduti dietro, che fanno le chiacchierate, venite, vi aspettiamo qui. I have so many things. I will begin by inviting the panel. We had somewhere the names, now they are gone, so I will use my own notes to make sure I don't miss anyone. So I'm inviting Silva Bon to join the panel, a person with lived experience here from Italy. Silva, ci sarà il nome da qualche parte lì, grazie. Yuri Kudipe, Director of Mental Health and Ministry of Health of Peru. Yuri, gracias. Atif Rahman, who is connected online and is already connected, I'm being told. So Atif, thank you for being with us. And Ellen Ronning Arnesen, State Secretary, Ministry of Health and Care Services in Norway. Thank you all. A last plea to the colleagues chatting in the back, finish your coffee and come to listen to this very important plenary session. And me. I introduce myself. I'm the director of the Department of Mental Health and Substance Use at the World Health Organization, and I'm the first speaker of this panel. I have a lot of documents and papers with me, so I will try to organize myself a bit, including the time. We can go with my... I will need the presentation. On the screen, la presentazione. Qui. Però la presentazione. At least we don't have to say, do you hear me? I'm there, and do you see me in the screen? We are all here in the same room. That's already something, right? Oh, ecco. Quindi, today we will talk about in this first plenary about community-based care, and the first slide was actually, well, I don't know, the title of the session, that is going towards community mental health services. So it was explained earlier, so I'm not going to repeat it. What is that we mean when we talk about community-based care? It was in the keynote speaker comments that community-based mental health care refers to everything that happens out of an isolated hospital-based care as the traditional psychiatric hospitals have been. And we think that there are a number of advantages to this community-based mental health care that are listed in this slide. The accessibility, the first one, we are talking about services that are close to where people live. We are talking about services that have less stigma for those going. We all know the stigma related to the old-fashioned traditional psychiatric hospitals. Going there, only crazy people go there, only mad people go there. We want services that are closer to where people live and that people can access without any concern about what others will say about this. We are talking about the protection of human rights. There is less risks of human rights violations in services based in the community. Not exempt, but definitely less risks than the human rights violations that happen or could happen in isolated institutions. And then, of course, the outcomes. There is enough evidence about the improved outcomes of people getting care through the services that are based in the community. So we believe that those services are an alternative to institutional care, and those services should be people-centered, should be recovery-oriented, and should be human rights-based. And you have there a picture of the World Mental Health Report that we recently launched, where all this is coming from, and that I invite you to look at and to read, hopefully. So, what kind of services are we talking about? We talk about a variety of services, and services that are, if properly developed, if properly combined, and if properly working together as a network, will provide answer to the many different needs that people with mental health issues may have. And we are talking about services, mental health services that are in the health sector, in the general health. We are talking about mental health services that are outside of the health sector, and we are talking about the community mental health centers services that were explained earlier and that are specifically run by mental health professionals or with a specific target or mental health. But we are also talking about the community that is around all those services that do provide also care in the context of mental health in a number of ways, and we are talking about community operators, but we are talking about us, people, families, friends, ourselves taking care of our own mental health. What we developed, and perhaps that's a bit of the a new way of presenting what we are trying to say, is this a model network of services. You can see the different colors of the three areas that I mentioned earlier, right? We are talking about the community mental health services in blue, and we talk there about mental health centers or mental health teams or peer-to-peer support, all the housing options, and many more. We are talking about mental health in general health care, primary health care, of course, first of all, but also services in general hospitals. And then we are talking about integration of mental health in other services, HIV, NCDs, NTDs, pregnant women, children, what role mental health has in each one of those other areas. But also then mental health beyond the health sector, schools, first of all, prisons, refugee settlements that we mentioned earlier, were mentioned earlier. So that is, we believe that no country has them all, or at least we are not aware of any country that has them all. But we truly, deeply believe that every country can improve the current situation they have in mental health by prioritizing, deciding where they want to start from, and start developing something that slowly and gradually will be getting closer to that model, ideal model of network. And then in the report, we suggest this path to transformation as a summary, conclusion of what we have stated and what we believe. And there are these three recommendations that are the main ones. And the first one is that we need to deepen value and commitment. Because mental health is important. I don't think there is more arguments needed. It is a value that when we have it, when we get close to it, when we can access care for it, and that value will lead to, hopefully, higher commitment. Higher commitment by leadership and policy commitment, but also, of course, financial commitment that is much needed as well. Strengthened mental health care, of course, as explained, is what needs to happen. Again, to our understanding, probably all countries could improve their mental health care network. And we will hear about this right now. And then the third transformation that is needed is reshaping environments. And by environments, we mean the community that we talked about before, homes, the network around us, the environment in general around us, and we need to make sure that the factors that influence our mental health are being taken into consideration from scratch to avoid risk factors and to promote protective factors in order to have a better development. So this is our summary and introduction to the session. Thank you. Now, I will... Thank you very much. I will now move... This work? So, I'm moving now. Yes, move now to this other position to introduce the panelists. The first one, la prima, è Silvia Bon, una persona con esperienza di vita che viene a raccontare.
She's a person with lived experience, and she will tell us how she's gone through her own path, her own experience within the context of the services that were offered to her. We will listen to her. You should.
Headphones, grazie. Thank you. Silva.
Thank you. Thank you for the kind invitation extended to me. Unfortunately, I cannot speak English, so I will use the simultaneous translation, and I will speak Italian. You know, I hear voices continuously, incessantly, even now. But today I'm okay. And I'm here because I want to bear witness in front of you of my treatment, a long pathway, so to say, full of ups and downs, full of suffering and tragic, extreme experiences. They put my resilience, even my human ability to endure many, many different moments in which I had to say that my life was jeopardized. All this was put to a hard test. When I think about the long period of time, almost 40 years since the onset of the mental disorder, up to the end of my treatment in the public mental services, I'm overwhelmed by a devastating wave of memories. But at the same time, I look with a sense of hope and even confidence to the future possibilities opening up for me, and I smile. For 30 years, I've been followed by the operators of the mental health department in Trieste. In that center, I was hosted, welcome, any time I had to face a difficult crisis. I often addressed directly to that center spontaneously, asking for help. The treatment organized by this center in Trieste has never been the same, nor only linked to the mere administration of drugs. I must admit that doctors, nurses took care of me in a very flexible way, open, empathic way, I would say. When I addressed to them in despair, overwhelmed by these terrible experiences of my life, when I was, please do not upload, when I was at the center faced with these operators and I was about to faint and I had blooding fit, I was destroyed physically and mentally. They helped me tangibly. They gave me a glass of water. They offered me comfortable shoes. They gave me a bed with fresh linen. They offered me some spaghetti. They listened to me and gave sense and significance to my tragic experience. And there were so many opportunities for growth through the sharing of socializing phases within self-help groups, thanks to workshops open to operators, family members, experienced people, as well as what I define as the gratifying and proactive protagonism. And I like to dwell on what I mean by proactive protagonism. Besides the drugs administered to me, prescribed by my doctors in the mental health center of Barcola, and obviously I addressed there because I had my residence in Trieste. For me, what was essential and fundamental was the process to reshape my very approach to life and my way of thinking. It may seem a sensational statement, but you know, change, although through suffering, was radical in my being a person, in my being a woman. I was offered a lot of opportunities for building and strengthening my self-esteem, my courage, awareness, responsibility and respect for myself and for the others. I had hit rock bottom. I was helpless, in despair, faced with the disease and with my uneasiness that blocked me, harmed me. I did not dare, I could not even look my counterparts, people that I cross in the street, perfectly unknown people, and I was afraid of them. I felt I was derided by them. Marginalized, I could not even get out of home apart from strict needs, deprived of any forms of affection and support, humiliated. I live an untenable family situation. And you know, the signs, the blows of the disease increased. I was speechless, closed. I couldn't do anything at all. I was put in a position to read, learn, understand, reflect, face difficulties, even hard challenges through the many opportunities created by this mental health department in Trieste, the center to which I always addressed. Opportunities that I seized, I could and was able to seize and enhance for my possible mental and physical well-being. I cherish great memories of that center, and I'm grateful to them until the pandemic. The Barcola Center was a welcoming center, and in the garden, in the shade of all the trees around the great table, there were spontaneous meetings of operators, hospitalized people, volunteers, people that looked for friendship and exchange of views. And, for example, the cook, any operator, any attendant were central. They offered us a coffee, sometimes some sweets. They opened the discussion, the group discussion stemming from the newspapers we read, and also with some advice or even reproaches given in a simple and humane way, and they open a reflection on individual problems. It was a center where the door was always open. I would say around-the-clock service. 7 days a week, a reassuring reality. You could go there without a previous appointment, without having to queue up, no waiting list, and there was the possibility of being cared of. They defined well-organized and well-considered responses to our problems thanks to teamwork. For me, it was of fundamental importance to continue with my work of teacher, to increase my theoretical and practical knowledge, live many different training experiences, participating in meetings as well as many congresses, both in Italy and abroad. Because, you know, building knowledge around mental health is something that pertains not only to the specialists, but must necessarily involve also family members, experienced people. Only in this way, through opportunities of exchange, knowledge, exchange of views, can we create a group, a community deeply entrenched on the territory, operating on the territory in view of improving the life of many of these people, and in order to strengthen collective mental health. Because there is no health, and this is my final conclusion, there is no health without mental health. Thank you.
Grazie mille per essere qui con noi.
Thank you very much for being with us today. Thank you very much for your courage to share such an experience, hard experience with this audience, but we can see the results of this experience. Thank you.
We move now to a second presenter that will show another component of this possible network of mental health care that we talked about, and that is Dr. Yuri Kudipe. And we ask Yuri to let us know from his own perspective what is that has brought Peru to prioritize mental health and provide the substantial investment that has been done for the development of a network of mental health services, and what has been your own strategy for developing those services over the last few years. So, Yuri.
Thank you very much, Deborah. Thank you very much to the Ministry of Health of Italy for the invitation. We need the presentation. Yes, please. Peru is a country with around 33 million people who is spread out over a vast territory with two mountain chains crossing the region, the Andean Mountains. This makes the geographical access from one region to another very difficult, especially to Lima, the capital city, which holds 30% of the population and the majority public services. In Peru, mental health disorders affect 1 of 5 adults, and there are the main cause of burden of disease, and the coverage of those conditions was roughly of 10%. Next slide, please. At the beginning of the current millennium, especially after the period of political violence and terrorism and the return to the democracy, there was a greater necessity to receive mental health care, especially for the population affected by the political violence and then by the survivors of the gender violence and violence against children and adolescents. This generates an increased awareness for mental health problems and a greater demand to the government for the policies regarding mental health services. Additionally, the Ombudsman Office reports offered a detailed description of human rights violations against people that were secluded in the 3 psychiatric hospitals of the country. In some cases, this violation lasted for more than 20 years. Next, please. Okay, thank you. Thank you. In the last year, it has been possible to implement a variety of community mental health services through a participatory process involving different levels of government across the 24 regions, all the regions of the country, with more than 3,000 psychologists in more than 1,000 primary care centers. In this moment, Peru have 248 community mental health centers, 56 brief hospitalization units in General Hospital, and 87 sheltered homes for people with long-term and severe mental suffering and without family protection. In Peru increased from 1 to 15 the list of essential psychotropic drugs delivered free of charge, and strengthening the capacities of thousands of health workers to carry out a diversity of activities of mental health. As you can see in the slide, we continue to open these services, which allows a remarkable increase in mental health care. The ongoing implementation of these new mental health services has allowed a progressive increase in mental health care coverage from 2013 Okay, thank you. From 2013 to 2021, in this line, a 9 to 11 coverage in 2013 increased up to 270% in the last year. All the efforts would not have been possible without an increase in the mental health budget. Another milestone in the process was the creation of a result-based budget program exclusively for mental health activities in 2015. In conclusion, experience has shown us that the most successful strategies towards a mental health care reform are spreading of tangible, territorialized, and specialized mental health services with a community perspective, boosting mental health care in primary care centers, strengthening community networks of each territory, promoting the active involvement of local governments in the process, bolstering investment in mental health. Previously, Peru allocated 1.33% of its national health budget to mental health services, of which 80% was assigned to psychiatric hospital. Now, the budget allocation grew up to 2.3%, of which 75% is assigned to community mental health services. We are fully confident that this is the correct pathway toward meeting the mental health needs in people that require attention. Thank you, Deborah.
Thank you, Yuri, very much. Thank you for taking the challenge of having your presentation in English to make it easier for all of us and to follow. And congratulations for the work done. I mean, from a personal experience, this is one of the most amazing changes in mental health that I have witnessed over the last couple of years, or few years actually. So thank you for your leadership in your country and also globally sharing with us your results and achievements. Next, we have Professor Atif Rahman that is already connected there. Atif is a clinical academic from University of Liverpool, and he couldn't come today with us because he is currently in Pakistan, where some of his work is also taking place. And the question for Atif is to show another aspect of the community-based mental health care that we've been talking about. And so what we are asking you, Atif, is you have extensive experience working with community workers, implementing task-shifting interventions for mental health. So could you please tell us about your work and the results that have been so far, and what are the main lessons learned? Over to you, Atif, and thank you for being with us.
Thank you very much, Deborah, and greetings from Pakistan, where I'm currently working with our partners to strengthen the primary care mental health response to the recent devastating floods. Unfortunately, the regularity with which we see such humanitarian emergencies underlines the importance of making mental health preventions more accessible in countries that need them. I wish I could have been with you in person. I put before you 3 lessons that we have learned from our work in low and middle income countries related to community-based mental health care. First of all, Deborah, as you mentioned, task shifting. So task shifting, or task sharing as it is sometimes known, is now considered a powerful evidence-based strategy of delivering mental health care. What task shifting means is that roles that have historically been preserved for mental health specialists, extensively trained over many years, can be taken up by non-specialists, who of course work under supervision of specialists. Let me give you an example from our own work in Pakistan. In low and middle income countries, 1 in 4 women suffer from perinatal depression, a debilitating disorder that causes great suffering and has negative effects on the infant. leading to intergenerational disadvantage. Talking therapies such as cognitive behavior therapy are highly effective treatments. But the tragedy is that for millions and millions of women with the condition, there will never be enough trained specialists to deliver these interventions. So what we did was that we worked with local communities and local providers in primary care to simplify the principles of cognitive behavior therapy so that this effective psychological treatment could be delivered by community health workers, lay workers, after brief training and on-the-job supervision. We called this program the Thinking Healthy program. We conducted the world's largest trial at the time in Pakistan, which clearly showed that these lay workers were very effective in successfully treating the depressed women. Such studies have since been repeated in many different countries and contexts with different target populations, and all have shown similar results. It is important to bear in mind that task shifting is not a second-class treatment or a cost-cutting ploy. In fact, many women prefer to be seen by a non-specialist from their own socioeconomic class that they can relate to better. It is less stigmatizing, providing the opportunity for the treatment to be offered at the doorstep. And the Thinking Healthy program is now a WHO program freely available on their website in 7 or 8 languages and is being used in a number of countries globally. The second point I would like to make is about the cost. In India and Pakistan, we experimented with peers, ordinary women from the community who were given a small stipend to deliver the program to other women from their own communities. Pool results from the 2 trials show that women who received the intervention had better and quicker reduction in depressive symptoms. But the point I want to make is that it cost only $1.36 to treat a woman with perinatal depression through this unique mother-to-mother program. That, ladies and gentlemen, is less than a price of a cup of coffee. My third and final point is about the scale-up of such programs. Training 50 community health workers in a research program is one thing. Training 100,000 community workers in the entire country as big as Pakistan is an entirely different proposition with its own sets of challenges. But that is exactly what we have been asked to do in 5 to 10 years by a person no less than the president of the country. Emergencies like COVID and floods make the job even tougher. With the support of the NIHR, United Kingdom, and the government of UK, we have for the last couple of years been working on a technological solution to this problem. So what we have done is that we have worked with users and our target population in these rural areas to co-produce an app, technology-assisted delivery system, through which a peer can deliver a powerful intervention based on the Thinking Healthy program. Basically, we have developed a therapist avatar which is programmed to deliver the therapy around the number of commonly encountered problems that the target population have identified. The peer and the avatar therefore act as co-therapists to deliver this intervention. The peers do not drift or drop in intensity from the evidence-based elements of the therapy, but at the same time, the peer acts as a strong source of support and empathy, which is so crucial for therapy. The app has inbuilt training and peer supervision modules, and the women with depression do not need a device or an internet connection. Only the peer needs a smartphone or a tablet device where the app can be downloaded and operated offline. This automated system of delivery is very promising, and we'll be finishing our trials in a couple of years, so please watch this space. I must emphasize one thing about technology, though. Technological systems of therapy must be subjected to the same rigorous testing as drugs. There are so many technological solutions or so-called technological solutions available on the open market, but if you closely examine them, they have not been subjected to any evidence-based exercise. That is critical to the developments that are taking place in the technology field. So ladies and gentlemen, to summarize, task shifting or task sharing is an effective strategy that can help reduce the treatment gap in a culturally acceptable manner. It is not only effective, but very cost effective, less than a cup of coffee. And technology can assist with scale up and holds great promise for making such interventions widely available. I leave you with this final thought. It is my firm belief that high-income countries have a lot to learn from such efforts being made in low-income countries. In the UK, we are experimenting with such approaches, which make the field truly global, and this reciprocal learning can benefit us all. I thank you very much for your listening.
Thank you so much, Atif. We have been learning already globally from your experience and the progress that you have made in with some of those initiatives you mentioned. I like very much the idea that we should not think about them as a second-class answer, but on the contrary, first class, extremely useful in many conditions, no matter the level of income of the country. And so thank you. We hopefully will have time to come back to you later. And our last presenter is as introduced before, the Honorable Secretary Ronning Anderson. And the question to you is that we know Norway is developing, undergoing an important process of expanding mental health. Our last presenter services. So was some microphone open somewhere, but here we are again. I was saying that Norway is undergoing a very important process of expanding mental health services and with a strong focus on community-based care. So could you share with us and tell us a bit about the process and what are your plans for implementation and how it has been possible to achieve political commitment and get that far and what's coming? Over to you, please.
Everyone's standing over here, so I'll do the same. So hello and thank you very much. And thank you everyone for sharing your experiences, and especially to you, Silvia, for sharing your lived life experiences. That means a lot for us who are trying to make solid policies. So thank you for the opportunity to speak on the importance of developing community mental health services. As we speak, as you said, we are working on an escalation plan, a new one which is affirming the community mental health approach. The World Mental Health Report underlines the importance of shifting both the public debate and especially the political focus towards a more sustainable mental health system. We think this issue is so fundamental that the Norwegian Agency for Development Cooperation partly also funded the report. We have heard excellent arguments for making this move from my fellow panelists, and I am here to add the political perspective to this discussion. In Norway, we have come a long way, I have to admit that. We also do have a tax-based universal healthcare system, which is important for making equality and equal rights to our system. Over the past 30 years, we have worked to increase the capacity and competences in the mental health services. However, we do find the increase in needs clearly outweigh any increased capacity we have managed to build. In Norway, more often than not, we still discuss that mental health services is concentrated on hospital beds, security wards, and inpatient health services. We need a new approach. We need to affirm the way we are moving as we are speaking of today. Therefore, I am happy that the Mental Health Report takes a more societal perspective on mental health services. This is a shift we need to make, and this is where our political focus are these days. The increase in mental health-related symptoms, especially amongst the youngest among us, cannot and should not be met with more treatment alone. This represents several political dilemmas which we actually do need to address. And we politicians, we like dilemmas because then we can show how we actually prioritize. which Mr. El Shamai also talked about previously today. But first and foremost, I would like to address the public health dilemma. Investing in public health to promote health and to prevent illness is investing in the long term. The effects of building health promotion communities cannot be measured as quickly as investments in new beds, more healthcare workers, etc., etc. For us politicians, that means that we need to think beyond the next election, which I had to admit sometimes is a bit hard. But as I heard my colleague from the UK said, for the price of a cup of coffee, you can actually do a lot. We need to remind ourselves of that. Second, there is the dilemma of what is needed versus what is wanted. We need a shift of mind in the population as well. We are working very hard on that in Norway as we speak. Because much of the traditional idea of what mental health services is, especially in Norway, is an illusion that it should be a therapy like Tony Soprano got, lying down on a couch, having a one-to-one speech, telling what is your trouble. But we need to expand the use of psychoeducation programs. We need more assisted self-help, online help, as we also heard, and we need more group interventions. We need workplaces to be better, and we also need activities to have a different approach. Because this will, for some, mean that the help which is offered will differ from the presumption and the expectations which we have. That is a crucial job for us politicians to show that this is the mix which is working, and that it is the broad approach that gives results on a societal level. Third, and most important, is the dilemma of shared responsibilities. Communities form the backbones of our societies. Communities are complex, interconnected systems. But from a governmental viewpoint, we tend to think that we have a sectorized system which you can address on a clearly administrative level, like a one-to-one lesson. As a former local politician, I can confirm that this is not the case. Mental health policies form the perfect example. Because excellent mental health services are at the best of temporary use to our society if kindergartens, schools, workplace, cultural activities, and communities fail to include, to support, and integrate. Because this is where the real work happens. It is akin to spending a fortune on a new motor on a boat which is actually leak. So we need all these functions to work at its best to actually make the effort worth the while. So making mental health, thank you, a priority in all policies is fundamental to succeeding in the move towards community mental health services. This is where we put all our efforts now. We need communities that plan for their citizens' mental health when they make area plans and regulate new buildings, as you were saying initially. We need communities that make the psychosocial environment as high as a priority as emissions regulations, water safety, and infrastructure investments. So succeeding in prioritizing mental health in all policies is, in my opinion, also a key to enabling social mobility and to closing the equality gap which we have in health. Communities offering real possibilities of social inclusion will provide a sense of place, belonging, and a purpose to us all. To achieve this, I believe in bringing together people with different backgrounds, knowledge, and expertise, exactly like we are doing here today, because people need people. Thank you.
Thank you very much, Ellen, if I may, and thank you for bringing also the experience of a high-income country that is going through similar challenges than others, and that in a way confirms, on one hand, the different models and opportunities, on the other hand, how everybody has room for improvement. And thank you for the generosity of the government of Norway that is not only focusing on the domestic issues, but is also supporting WHO to support other countries going through similar processes. So thank you very much. And if I'm not mistaken, we still have a few minutes, and so I will invite all colleagues in the panel say a few more words, if after listening to the others, if there is something, a final comment that you want to share with us. Silva?
Sì, io volevo ringraziare lei.
Yeah, I would like to thank you and the whole audience for the patience, for having listened to me and to have listened to me, my contribution. I'm here for all the people, my friends that I met throughout the years, people, and I represent people who cannot speak today. Thank you.
Grazie ancora, Silva.
Thank you very much, Silvia. Thank you for being with us today. Yuri?
Only for remember, deep in value of mental health is the transformation of the environments and healthcare to mental health care of all the persons. College, excellencies. In this moment, after 20 years of pathways of discussion about what is the best model of services for mental health, we have clarity what is the pathway. But in this moment, in all countries, the people need services, especially now by the pandemic. And we need to fight for more budget. 1% of the budget for mental health of the mental budget is more important, is the difference between the past and the future of the people in our countries. Thank you.
Thank you very much, and we hope everybody will get that suggestion and advice and comment. Atif, over to you, a final comment.
Yes, thank you, Deborah. I'd just like to say that maybe we need to reconceptualize the word mental health provider. You know, all of us, every human being is a mental health provider. And some of us are maybe facilitators or enablers. And I think that that must be kept in mind when we develop interventions. And the most important people who should guide, you know, our research and our policies and our efforts are people like Silva, you know, who have a rich lived experience and are such a huge resource for telling us how we should shape our services so that they can benefit the people. All of us, actually, all of us, or most of us, will at some point go through some crisis that will require some degree of help. And so it's everyone for everyone, not just mental health providers sitting in a castle trying to do things to other people. Thank you.
Thank you, Atif. I guess mental health is too important to leave it in the hands of mental health professionals only. Thank you very much. One more comment from your side, Ellen.
Thank you. And I would like to reaffirm this and this last word said as well, because health cannot be left to the health sector alone. To broaden the perspective of mental health and to prevent stigma and to ensure human rights, we need a big shift of mind. And I'm so glad there are so many fellow colleagues here today to prove that we actually want to make that change. And I would also like to remind, especially us in the high-income countries, also to make sure that we actually do evaluate and that we actually do document the changes that we make in our system so that we make sure that we can give sort of the proof that this is working. I keep reminding myself that every day when I go to work, that we need to show why this shift is necessary. So I'm very glad to be here today, and I'm happy to speak to all of you later on. And thank you so much for inviting us here.
So, dear colleagues and excellencies and the audience in general. I hope you got a glimpse of what could happen and how many great things are actually happening in different contexts and in different countries. And I hope that inspire many of us to keep going in this transformation that is needed for all of us. I want to thank the Italian government, Minister Speranza, and the team because of the privilege of being here at this first panel opening and perhaps setting the floor and the giving some initial suggestions for the discussions to come. Thank you, and good to go now with the next panel.
Ladies and gentlemen, please welcome Mr. Francesco Rocca, President of the International Federation of Red Cross and Red Crescent Societies.
Good morning, dear Minister Roberto Speranza, Your Excellencies, dear participants. I'm Francesco Rocca. I'm the President of the International Federation of Red Cross, Red Crescent Societies, and I'm also the President of the Italian Red Cross. This panel, as you know, will be dedicated to discussing about people in vulnerable settings and their specific challenges, why they need to be prioritized in the provision of mental health and psychosocial support, and how it is crucial to ensure justice, dignity for those affected, and social cohesion. And we have brought together experts from international organizations and member states engaged in providing support to people in vulnerable settings, who will share with us experience-based insights to get a better integration of mental health support to people in vulnerable situations. And I will be joined in this discussion by 6 distinguished guests who kindly accepted to share their insights and contribute to the discussion. So here in the room with me we have Alan Berset, the Federal Chancellor of Swiss Confederation, Omar Adbi, the Deputy Executive Director for Programs of UNICEF, Monica Gorachi, the Director of the Department of Program Support and Migration Management at IOM, and finally, Rebecca Smith, Global Health, Child Protection Programs and Save the Children. Online, we have the pleasure of counting with Ksenia Vozditsina. I hope she's connected. Ksenia, she's a Chief Physician of the Center for Mental Health and Rehabilitation of Veterans in the Ministry of Health in Ukraine. And finally, my friend Mahesh Gunasekara, Director General of Sri Lanka Red Cross Society. As you know, over the last decades, mental health has progressively advanced towards recognition of its importance and how the quality of mental health impacts all aspects of life, from physical health to professional success and social integration. And within the Red Cross and Red Crescent movement, we have worked in developing a common policy for addressing mental health and psychosocial support needs, same as we adopted a resolution with member states in our last international conference, calling for increased action on addressing the mental health and psychosocial needs of people affected by armed conflict, natural disasters, and other emergencies, in recognition that these circumstances create situations of vulnerability and expose individuals to situations of fragility. Nevertheless, need has systematically outpaced availability, and the barriers to finding, accessing, and affording mental health services has been especially devastating to the most vulnerable, who face already critical circumstances that challenge their mental health and psychosocial well-being. People on the move, women and children, people with disabilities, elderly or indigenous communities are among some of the most vulnerable, to whom the need may be bigger but availability shorter. However, there can be no exhaustive list of groups in situation of vulnerability. For some, circumstances create the vulnerability, while for others it exacerbates. Context of war, displacement, social and economic instability can trigger circumstances that challenge people's capital resource and resilience. Inversely, vulnerabilities can exacerbate risk for mental health and lead to its deterioration. Individuals facing stigma and discrimination as a consequence of their vulnerability can experience a low self-esteem, decreased self-confidence, reduced motivation, and less hope for the future, as well as promote isolation, considered an important risk factor for the emergence of mental disorders. Therefore, it is imperative that people in vulnerable settings are granted access to mental health and psychosocial support as part of a holistic and integrated care that recognizes mental health risk as a vulnerability in itself. For us, in the Federation, this is part of what we do daily, while working in the most remote places, reaching the last mile population and prioritizing vulnerable groups in our action. And our Red Cross Crescent movement, the mental health and psychosocial support framework, encompasses a protection circle that includes promoting access to rights in accordance with international laws and upholding people's dignity through providing principled assistance according to the 7 fundamental principles. Examples of activities include advocating for ensuring people living with mental health conditions and psychological distress and are enabled to access the necessary services. So before turning to the panelists to start the discussion, as a president not of the Federation but of the Italian Red Cross, let me use this occasion also to thank the Minister Speranza for the constant support that he has given to the role of the Red Cross in advancing the mental health and psychosocial support agenda, with several concrete examples, the last one, unfortunately, in providing psychosocial support in Senigallia during the recent flood that affected the region. So with this, I will have the pleasure to give the floor to the first speaker, which is an honor to have with us, Alan Berset. And I have a question for you, dear Minister. The vulnerable groups exist in every country and cannot be disregarded. What is exactly the situation in Switzerland, and what measures have been taken to ensure access to mental health and psychosocial support for everyone? Thank you, dear Minister.
So, dear Roberto, ladies and gentlemen, dear panelists, experts, colleagues, first, let me thank the Italian Ministry and you personally, Roberto, for organizing this very important event and also for having invited us to participate. Thank you very much. It's a great pleasure to be here with you today. I think, ladies and gentlemen, that mental health must be a priority in all our health systems, and it is my pleasure to be here with you today and to tell you about the situation in Switzerland, what we are doing in Switzerland in this regard, and to share our experiences with you. My first point is this point. Mental health concerns everyone individually, but also our societies, our communities as a whole. This was also the key message of our national mental health awareness campaign in Switzerland. And if we say that, we must not forget that vulnerable groups tend to be more affected by mental health disorders, and in return, mental health disorders can make also people more vulnerable. And there is a close link between mental health and vulnerable groups, and it is our duty also in our role as experts or as on the political level, it is our duty to ensure that our societies leave no one behind. And my second point will be the next one. In Switzerland, nearly one third of the whole population suffers from a mental disease, and these illnesses are amongst the most common diseases in our country. They affect people from any age group. They affect people from all social backgrounds, from all economic backgrounds within the society. And we have noticed that psychological distress has increased since the beginning of the pandemic. The number of people affected has more than doubled amongst the young people between 17 and 21 in Switzerland. We've seen also that hospitalization for mental disorders has been rising continuously amongst children and teenagers since 2012, and similarly since 2017. Hospitalizations with regards to suicide attempts have clearly increased among children and adolescents, mostly girls and young women. And as you can see with these statistics, there is a clear need for action, and we recognize that in Switzerland, a clear need for action, and we identified young people as one of the vulnerable group to take better in the focus. And I come with that to the third point. As we decided to put a special focus on the young people, and given to the federal structure we have in Switzerland, given to the federalism, the cantons, the regions are responsible for the provision of healthcare, including mental health care. And at the Swiss level, at the government level in Switzerland, we are working in three main areas. First one, promotion. Second one, prevention. And the third one, transmission. What does it mean? Promotion of mental health awareness and well-being. Prevention is to improve prevention and to improve early detection also for young people. And the third point, transmission, is to ensure that the transmission of knowledge will be good among the numerous actors involved. And I will take the occasion now to give you some examples what we did in this regards. For the promotion, we launched a dedicated website to disseminate information on mental health and promote psychosocial skills among the general population, including the young people. For the prevention, more recently, we have been working on recommendations for strengthening mental health, early prevention, early intervention in school, at school level. And the third point, transmission, with this objective to exchange information and knowledge, we created the Mental Health Network Switzerland with the most important actors in the field. That's what we did in the past, in the recent past. And well, despite these efforts, we know that there is still room for a lot of improvement. Maybe last few words, and I make that in French because it is for me also quite emotional. Nous avons naturellement pu constater, mesdames et messieurs, cher Roberto.
We have realized, dear Robert, that the situation of the pandemic has not created new problems, but has brutally pointed to existing problems. What I have just told you about Switzerland so far shows that the problem of mental health, and I presented the case of young people, this issue has evolved over the years, and it has been accentuated and worsened by epidemic. And here we have to grasp the opportunity at the political and technical level to work not only in the healthcare sector, but also in the training and education sector. Yes, there are politicians. Politicians manage public finances, so we need them, obviously. And I would like once again, Minister Speranza.
Thank you very much. Now we should have online Ksenia Vosnitsina. She is online. Welcome to this panel. As I said, Ksenia is a chief physician at the Center Center of Mental Health and Rehabilitation of Veterans in the Ministry of Health in Ukraine. So, Xenia, for you, I have a question. War and conflict is certainly one of the circumstances that forces people into a situation of vulnerability. For some, it might add complexity to already existing circumstances of vulnerability, like is in the case for elderly people or individuals with disabilities. But how has the conflict in Ukraine impacted the mental health and psychosocial support, particularly of those who are already in vulnerable circumstances? And how can a country adapt the health system to respond in such challenging circumstances? So, Xenia, the floor is yours. Ukraine impacted the mental health and psychosocial support, particularly of those who are already in vulnerable circumstances, and how can a country adapt the health system to respond in such challenging circumstances? So, Xenia, the floor is yours.
Hi, everyone. Do you hear me?
Yes, loud and clear. So, Xenia, the floor is yours. Xenia?
Hi, everyone. Do you hear me?
Yes, we hear you loud and clear.
Today I would like to talk about the effect of war in Ukraine on mental health of our people.
We hear you loud and clear.
Today I would like. Also, I would like to think what Ukraine can do to address the current mental health crisis and how the global community can support us in this struggle. Since 24th of February, 1/3 of Ukrainians have been forced from their homes. In combat-affected regions, people suffer from hostilities. They lack food, drinking, water, and basic medication. Everyone in Ukraine lives under the permanent threat of air attacks. Every day, dozens of Ukrainians get seriously injured. Many military and civilians lose their limbs. Over 1,000 Ukrainians lost their limbs during the first 3 months of war. The war is affecting physical and mental health of many people in Ukraine. It hit especially hard the most vulnerable population, like people with disabilities and elderly people, who have not been able to evacuate from the hostilities and who are struggling to find safety. According to World Health Organization, 1 in 5 people from combat zones will have mental disorders within 10 years and may need psychological support and treatment services due to war-related trauma and stress. So we need to adapt the healthcare system to meet emergency needed. Ukrainian mental health systems was mainly focused on biomedical approaches. Mental health services were provided in inpatient psychiatric hospitals or units. Many people and agencies in Ukraine, including the Ministry of Health, Ukrainian government, international organizations, and donor agencies have already united efforts to develop an accessible, affordable, and high-quality mental health care system. These efforts are pioneered and supported by the National Mental Health and Psychosocial Support Program of the First Lady, Olena Zelenska. The Ministry of Health works to integrate mental health services into primary health care in order to close the gap in treatment of mental and substance use disorders. We already started to train family doctors to identify and treat the common mental health and substance use disorders. We will also develop community mental health centers all over Ukraine. These services will be paid by the state and will become more accessible, in particular for vulnerable populations. In war, 330 healthcare facilities in Ukraine were damaged or completely destroyed, but we are doing everything possible to restore the provision of medical and psychological assistance. The Ministry of Health also supports the work of mobile mental health teams, which provide community-based services for hard-to-reach populations. Currently, we have 78 teams, and their numbers is growing. The Ministry of Health is also developing high-quality specialized services for people who have suffered from war. In order to improve the rehabilitation services, we will complement the program of medical guarantees, the complex inpatient rehabilitation assistance for adults and children. Ukrainian governments, NGOs, and other agencies are doing the best to save and restore people's health and well-being. But we have to admit that our resources are limited. Our economy may shrink by up to half because of the war. We will need sustainable support from the world in the upcoming years. We need help in the following areas: development of mental health services in communities, restoration and modernization of healthcare facilities and making them accessible for people with disabilities and for elder people, opening more mobile mental health teams, opening outpatient mental health center at healthcare facilities, sharing of knowledge and best practices. Many mental health experts in Ukraine believe that we will be able to prevent catastrophic situation with mental health. Ukraine is experiencing the war in support inside the country and with support from the world. We can openly talk about our trauma internally and on the global level. We are coping with traumatic events with humor, heroism of our soldiers. We also transform our trauma through constructive action, like rebuilding, destroying homes and infrastructure, volunteering and donating. And the most important, we have senses and values that are more powerful than trauma. We stand together against the evil. We defend our country, its values, human rights and democracy. Together we will win, and I hope that together we will build a safer and healthier world for everyone. Thank you very much.
Thank you so much, Kenya, for your very clear and direct presentation, a very comprehensive one. And on a personal basis, also let me thank the Ukrainian Red Cross volunteers that are working around the clock in close cooperation with the Ministry of Health and scaling up for the communities, the psychosocial support and providing mobile clinics. And I'm very proud about the role that they are playing during these difficult times. So thank you once again, Ksenia. We move now to another speaker, Omar Abdi, is the Deputy Executive Director of Programs at UNICEF. Omar, the children are certainly a group that deserve special attention, as they are particularly vulnerable, irrespective of the situation they are in. We know from research that particularly the early years of life will be critical to determine their personalities and the inner resources they will develop to interact with others and cope with challenges throughout life. So can you expand on why children need to be prioritized in service provision and give example of how that can be done? About young people, we just listened to the federal counselor, but it's good to listen without more comprehensive, with a global vision on it. Thank you very much.
All right. Thank you, Francesco, and thank you, colleagues, Minister and others, for putting children and adolescents at the center of this discussion. I mean, first, all children and adolescents and their parents and caregivers are at risk of poor mental health outcomes. However, risks are particularly acute for the most vulnerable. For example, those who live in humanitarian emergencies and low-resource settings, those facing violence, neglect, and abuse in the home, or those living with disabilities. In different contexts, race and gender can also play a role in determining mental health outcome. So mental health problems are common in children and adolescents who witness or are exposed to extremely distressing and traumatic events. We estimate around 8 to 10% of children develop stress-related disorders, including post-traumatic stress disorder, PTSD, and a higher proportion will develop other mental health problems, including behavioral and conduct disorders, anxiety and depression, as well as problems related to substance abuse. Earlier this week, we launched a mental health evidence gap map on the effectiveness of child and adolescent mental health and psychosocial support. Interventions in low and middle income countries showing that the field is reactive rather than proactive, with most interventions focusing on treatment rather than promotion or prevention, as my colleague earlier mentioned. Promotion and prevention are critical and can be achieved by strengthening systems for mental health across sectors, and not only health sector, as the Norwegian colleague mentioned. So what are the agencies, UNICEF and Red Cross and other partners are doing? First, clear guidance on essential mental health actions in emergencies has been lacking in emergency response. Therefore, the new mental health and psychosocial minimum services package developed by UNICEF, WHO, UNHCR, and UNFPA provides a practical and clear guide on exactly what to do for mental health and psychosocial service in an emergency setting across sectors. So governments and civil society organizations, implementers are encouraged to follow this new interagency guidance to ensure essential actions are prioritized and the quality of mental health and psychosocial support response in emergencies is improved across sectors. Second, workforce is the most important asset for service delivery in mental health care, especially in emergencies. Ensuring the quality of the training the workforce receives is therefore essential to quality of care. UNICEF and WHO have created EQUIP to ensure development and demonstration of competencies of mental health and psychosocial support workers. EQUIP is a tool that can be integrated across sectors and type of workers to ensure that core competencies for delivering interventions are demonstrated for success. Third, in the absence of care interventions for the youngest and most vulnerable children, UNICEF is currently developing a psychological intervention to be delivered by non-specialists for younger children and their families. This is a critical gap in mental health care, often leaving behind children under 12 and their families without specialized mental health services. Support for testing and rolling out evidence-based interventions such as this is essential for improving both the evidence base and access for children and families. Fourth, schools and other learning environments, especially in humanitarian settings, play a unique and vital role in the lives of children and adolescents. UNICEF and partners are working with governments to guarantee sustained support for education systems to promote positive mental health and address the mental health and psychosocial support needs of all learners. Fifth, good programming, of course, starts with good data. Currently, there is a large gap of data on adolescent mental health. Available data represents less than 10% of the young population globally. UNICEF is working towards closing this important data gap through the development of a set of validated tools to collect data on key aspects of adolescent mental health, including prevalence of mental illness, functional limitations, suicidality, care seeking, and connectedness. These data will equip stakeholders with the evidence they need to effectively respond to the issue and improve children's, adolescents, and lives. And finally, emergencies and fragile settings place parents and caregivers as first-line responders for children's survival, care, and learning. However, the caregivers struggle to cope with multiple stressors and provide nurturing care to their young children and to engage them in developmentally appropriate learning activities. UNICEF, with the support of the Lego Foundation, has developed the Caring for the Caregiver package, which promotes caregivers' mental health and emotional well-being and enhances continued provision of good care and stimulation of children, a rare opportunity in emergency settings. Thank you.
Omar, thank you. Thank you so much. And on a personal basis, just to thank twice for underlining the importance of data, so how vital they are for us working on vulnerable settings, the lack of data in 2022, which is unforgivable. You know, this is vital to provide assistance to those in need. Now we move to another speaker, Monica Gorachi, the Director of Department of Program Support and Migration Management of the IOM. When we talk about people in vulnerable situation, migrants come to mind, or maybe should come to mind, but too often are the neglected ones. And migrants and people on the move, irrespective of legal and social status, are indeed subject to specific stressors and enjoying an asymmetrical access to mental health care when they need it. Those forced to migrate to conflict, climate change, economic hardship face specific challenges and obstacles. And behind the numbers we see on the media, there are individual people, each with a story, an ambition of a better tomorrow holding them up. How does uprooting impacts the mental health and psychosocial well-being of individuals, and how can this be addressed, considering the added challenge of addressing those on the move? Thank you, Monica. The floor is yours.
Thank you very much. I tried to be eco-friendly and not bring the good old paper, but it's very slippery here, so I hope I don't lose my iPad. So thank you very much for inviting IOM. I would like to focus on three main aspects. One is vulnerability, access to mental health care, and what we have learned in IOM through our work. In the context of this workshop, vulnerability is understood as both a reason and an outcome of marginalization, which can impact mental health. And vulnerability plays a very big part in today's discourse on migration, which is a discourse that wants migrants as vulnerable individuals needing assistance or bringing vulnerabilities into societies, be they host or transit, while very little attention is unfortunately given to their capacities, their contributions, and resilience. In reality, if we accept the definition of a migrant as that of a person who moves away from his or her place of usual residence, whether within a country or across an international border, whether temporarily or permanently, then we see that the experiences of the 1 billion migrants in the world are varied. And most migrants are not necessarily or intrinsically vulnerable. You have exchange students, international civil servants, migrant workers, academics, qualified managers and experts, domestic workers, transnational families, and seasonal workers. This does not mean clearly that there are no vulnerable migrants. Much to the contrary, for many, the migration path implies irregularity and risks of exploitation. Victims of trafficking, unaccompanied migrants and separated children, irregular migrants, but also refugees, asylum seekers, internally displaced persons. Because the public image of migration is mostly associated to this path, all migrants are seen as more vulnerable to mental disorders than other populations. But in reality, research investigating migrants' vulnerability to mental disorders is really inconclusive. And it's important to avoid generalizations, as it is always a unique combination of life history, of conditions of the present, social support, access to care or integration assistance that determine mental vulnerability of migrants. And at the same time, if we take all of the above criteria, nothing really suggests that migrants are less vulnerable to mental disorders than other populations. Therefore, it is important for us that migrants' access to mental health is better addressed through the lens of rights rather than the one of needs. And this is very well framed in the Agenda 2030 that calls for mental health care that leaves no one behind, or in the more recent compact on refugees and the compact for safe, regular and orderly migration that calls for universal access to health care. Now, this emphasis on migrants' need for mental health care is not matched by an adequate offer of services. Independently of social or legal status, or the reasons why migrants left their countries, they encounter very asymmetrical obstacles in accessing mental health care. And this has to do with exclusive and categorical access to healthcare in general, with lack of information, double stigma, fear of registration for some migrants, or lack of linguistic competencies and cultural understanding in the service provision. If we take irregular migrants, they often have the right only to primary and general health care, while in many health systems, mental health is provided only at the secondary or the tertiary levels of care. And additionally, most psychotherapies in the global north are based on talking and cultural practices, and migrants may be left behind or feel they're left behind if they don't speak the language. So IOM has been providing MHPSS to migrants, displaced retinee populations and host communities since its inception, but it grew stronger in this work since 1999 with the creation of a dedicated hub to mental health and psychosocial support. In 2021 alone, in the whole organization, we've assisted more than 1.5 million individuals in more than 80 countries with MHPSS support. And the main areas of work are emergency and humanitarian response in South Sudan, Cox's Bazar, Iraq, Chad, Lebanon, to name a few, and more recently in Ukraine as part of the as part of the First Lady's initiative that we heard referenced before. We've offered mental health services in the communities through dedicated psychological support hotlines and mobile teams, and trained frontline workers and mental health professionals. And similar work has been carried out in the neighboring countries, where we reached a total of 30,000 beneficiaries. The second area is direct and community assistance to victims of trafficking, resettled refugees, unaccompanied and separated children, and migrants in the voluntary return process. We have trained law enforcement, migration professionals, and mental health professionals in providing assistance to those migrant groups. And the third is in mainstreaming mental health care in peace building and development processes, as supporting the mental health services provision, for instance, within reparation processes, such as in Sri Lanka. And through all these different experiences, we have learned 4 more things. We've learned that it is important to grant all migrants, irrespective of status, access to primary, secondary, and tertiary health care. To make mental health care accessible from many systems that migrants get in touch with, and we've heard this 360-degree approach, with such as like law enforcement, social care, or educational ones. To grant services that are culturally and linguistically accessible to migrants, including outreach and creation of competencies within the same migrant communities, and to focus on services that are community-based, that engage migrant communities in the design and in the provision of services, avoiding the creation of parallel structures and utilizing resources available in these communities. So to summarize and to conclude, what we want to say is vulnerability, including to mental health disorders, is not necessarily related with the conditions that led people to migrate, undertake dangerous travels at the hand of smugglers and traffickers, or to be criminalized, be detained unlawfully, and for uncertain periods of time, stigmatized and prevented to access services. Therefore, we would like to really caution against linking vulnerability to migration, also in regard to their mental health needs. Many of these needs could be minimized if migration was managed, devoting more attention to the possible effect on well-being of bureaucratic, political and systemic decisions that very often are at the basis of migrants' distress. IOM is committed to continue supporting member states, service providers, and migrant communities in better understanding the mental health of migrants and in finding appropriate solutions so that no one ever is left behind because of social class, legal status, or the color of the skin. Thank you very much.
Thank you, Monica. Next speaker is should be online, Mahesh Gunasekara, and I have a question for you. Sri Lanka has been impacted by multiple crises in the recent years, from natural disasters to the economic crisis and social instability. And when we talk about people in vulnerable settings in Sri Lanka, it's probably hard to prioritize as the impact has been long-lasting and multifunctional. How has the Sri Lanka Red Cross Society been able to prioritize target groups, and what have you observed in terms of the impact in the mental health of those that your national society is serving?
Thank you, Francesco. You all hear me?
Yes, loud and clear.
Okay, good. Thank you, Francesco. Dear Excellencies, colleagues, and thank you very much for us giving this opportunity to be the voice of people on Sri Lanka. Yes, as Francesco said, it's indeed hard to prioritize. But in my eyes as a humanitarian professional, which is not for me, especially when we see that in terms of psychological impact, everyone is affected one way or another. As you all know, Sri Lanka is going through a worst economic crisis since the independence in 1948. This has been exacerbated by a series of overlapping events, beginning with COVID restrictions, then country's inability to pay imports, and there is civil unrest, so on and so forth. And this is a country coming out of an armed conflict that lasted for 3 decades, causing enormous physical and psychological suffering across the country. In a post-war era, a study in 2014 found that there were about 14% prevalence of emotional and behavior problems in primary school children in Sri Lanka. The peace and stability over the following decade were disturbed by a series of bombing again. On Easter Sunday, targeting Catholic churches and the luxury hotels in 2019, killing more than 250 people with extensive psychological and emotional suffering among people across the country. At the beginning, the current crisis, there were shortages of food and fuel and daily power cuts. And it's within the really context of the COVID pandemic. Still, it's not over. This has improved somewhat, but the currency losses, buying power, inflation has continued to bite the most vulnerable, who are unable to afford the basic necessities such as food, fuel, and medicine. Very, very basic things. The list goes on. The situation in the country is dramatically deteriorating in every month, really the passing month. Inflation keep on rising. Last month it was 70%. The food is becoming very unaffordable for people. It's becoming a large food issue. Food inflation is about 94% in the last month. The affordability of the people's ability to really, purchase food is becoming a major issue. The impact on the health sector is huge. About 80% of supplies are imported. The medicine stocks in the country is at a very critically low situation. Medical procedures, including emergency surgeries, have been cancelled regularly. Access to healthcare is continuously deteriorating. Food security is becoming a major concern. Child malnutrition is worsening due to loss of income, cutbacks due to really unaffordability, school meal program. While a recent study, what we have done very recently, we will be launching it tomorrow. There are lots of families report skipping meals or skipping their preferred food just to save money, because they can't afford it. There is no animal protein in their meals. With a very recent, according to OCHA, around 6 million people, that is 25% of the country's population, is in urgent need of humanitarian assistance, with an estimate of 5 million experiencing food security. These are very large numbers for a country like us, and which is going through economic crisis. So where feeding the population is becoming a major issue. Household economic stresses have resulted rising in welfare and protection concerns of most of the vulnerable people, such as really people living below the poverty line, people with disabilities, marginalized people. Children is one of the major groups which has been badly affected. Domestic violence, sexual and gender-based violence, serious child protection incidents are reported, and they are continuously on the rise. Newspapers are reporting that more and more parents are placing their children in institutes, while welfare of the children left behind when their parents walk away from the home in question. So now, schools has been closed for a long time, then now they have been opened due to COVID and due to fuel shortages. Now parents are struggling to send their kids into school just because of higher cost of transportation, food supplies, and supplies for them. The current crisis has led to a significant psychological distress and despair among children, adolescents, and youth. A survey among medical graduates done very recently, during the pandemic, they found depressive symptoms are among 40% of them. Anxiety is around 34%, and elevated stress levels are around 25%. In a survey very recently conducted in Eastern Province, found that 75% of school students are studied had increased stress and anxiety. The reasons identified as closed schools, physical isolation, and unexpected changes in their lives. Just looking at this background, what I have just spoken, really, all these factors I mentioned above can cause significant psychological stresses, making people vulnerable to developing psychological morbidity. However, as many of you all just said, that really the services are not adequate enough for people to access, because in the country, still really we see the mental health services are more on primarily hospital based. We don't see a community based mental health service going on. Sri Lankan schools and then health systems lack of structured standardized counseling services due to negative perception and the unwillingness to invest in mental health. So we as Red Cross, really what we were trying to do is basically trying to provide basic psychological first aid services and advocating for the decision makers to take the mental health services into the community. So that is an area but we have been doing some work, but really, the scale has not been adequate enough to cater the need. So this has been a forgotten crisis, fallen between the cracks, but it's a complex humanitarian. It checks all the boxes of the complex humanitarian emergencies. If immediate needs has to be taken in to uplift the psychological well-being of the population, and normalize the psychological environment. If we don't take action now, it will be too late. So, and if we were talking about leaving no one behind, I think if we don't take action now, we are going to leave a lot of people behind. Thank you.
Thank
Thank you very much, Mahesh, for your insights. Now we move to our final speaker, Rebecca. Rebecca is a global head of child protection programs in Save the Children. Rebecca, we have just heard from Omar why children need to be prioritized in service provision, and they've shared some example of how this can be done. So can you share some concrete example from your work in over 120 countries in supporting the mental health and psychosocial well-being of children and their families? Thank you, Rebecca. The floor is yours.
Thank you. There are 3 points I want to make connected to our findings from our programming across the globe, including here in Italy. The first is that investing in preventative programming is essential. I'll never forget visiting newly qualified social workers in Indonesia and finding one of the challenges they were facing was in closing cases. Families did not want to lose the support of their social worker, as they felt having a social worker support their family was a huge benefit and even made their neighbors a bit envious. Many of you know this is not how social workers are commonly viewed in Europe. Lack of investment means many preventative services are cut. Social workers respond to families with limited solutions or time available, and often after harm has already occurred. But social workers are key to providing holistic preventative approaches to children and their families to support mental health and well-being. Early support fundamentally changes how social workers and community health workers are viewed, respected, and welcomed into a family. Of course, the key to providing preventative and supportive services is to ensure that people providing those services are well-trained and supported to do so. This brings me to my second point. We need to strengthen both the capacity of the workforce and the capacity of children and parents themselves. Traditionally, services to vulnerable children have been provided through religious groups and volunteers, often unpaid women doing their best to respond to issues that the broader society would rather forget. Over time, however, we've realized that best intentions and goodwill are no longer good enough. We need government policies, we need adequate funding, and we need a professional workforce to support voluntary efforts. As such, Save the Children works to strengthen the capacity of NGOs and government staff, using packages like Equip, which was mentioned by Mr. Omar, to provide MHPSS services. We also lead a competency-based framework called Compact, in which our staff demonstrate the skills needed to be a child protection professional, including the necessary MHPSS competencies. Because ultimately, working with someone at their lowest, especially a child, helping them find their strength that they have somehow lost, requires practice and supportive supervision. It's not something you can simply learn in a book. Strengthening capacity should also be community-based and thus include caregivers and peers. An example of strengthening community support is the I Support My Friends program, whereby adolescents use their own experiences to help each other, sharing knowledge, providing emotional support, and offering practical help. We know from our work on the ground that children affected by conflict, public health emergencies, and climate change have an increased risk of mental health concerns, and yet they're often the most difficult to access. The impact of COVID-19 cannot be underestimated. Research in Italy showed that 72% of parents deem their children more nervous, uncertain, and insecure following the pandemic. Our recent research with refugee and migrant children moving across Europe illustrated that children do not often trust institutions such as healthcare, schools, and child protection services, partly because these institutions are only sporadically in a child's life, making it challenging, if not impossible, to access mental health services. So my third point relates to access and integration. To achieve universal coverage, we need to provide MHPSS services and support to where children are, instead of waiting for them to come to us. In that vein, we welcome the conference focus on community-based solutions and integration, like including MHPSS in the basic package of health services, as was mentioned by Dr. Voznitsia from Ukraine. It's important that we remember that the issues of children and families face are complex and multi-sectoral. We must integrate MHPSS into a variety of systems that children and families naturally come into contact with at the community level to help reduce stigma and ultimately provide better outcomes for children. In our programming, some examples of integrated responses include, for example, in Yemen, where health workers recognized that high stress, anxiety, and depression were making it much harder for mothers to breastfeed and bond with their own children. In response, we integrated MHPSS into our health and nutrition programming and supported the government to integrate a focus of common maternal mental health challenges into their national guidelines and training for health workers. Globally, we know that children of mothers with depression are 1.5 more times at risk of being malnourished and stunted. Another example is from Cox's Bazar in Bangladesh, where we're conducting a randomized control trial to see the difference between providing a standalone positive parenting program with a WHO cognitive behavioral therapy package called Thinking Healthy to improve parental practices and health outcomes. Here in Italy, we train educators and coaches on activities for children based on movement, nature, and sharing difficult experiences. Psychologists are available at drop-in centers for unaccompanied and separated children, and individual support is offered for Ukrainian mothers at the hotels they're staying. We also provide a toll-free hotline to address requests from families on difficulties faced by children and following the pandemic. To meet the wider complex needs, Save the Children is also investing in integrating quality, accessible, and inclusive MHPSS services across all sectors. We've endorsed a cross-sectoral MHPSS framework investing in community-based and led interventions, family strengthening, peer-to-peer support, and building the capacity of parents, teachers, and local organizations. We're committed to implementing the minimum services package that Mr. Omar mentioned and have developed technical guidance to support countries in practical ways to do so. In 2021, we supported approximately 800,000 children and 1.5 million adults with or without disabilities to access MHPSS services in more than 100 countries. So briefly to reiterate my 3 points, to improve outcomes for children in the most vulnerable circumstances, we must invest in prevention, strengthen and empower the workforce as well as community members, including children and their caregivers, and provide holistic MHPSS support to children through community-based services they naturally come into contact with. Thank you.
Rebecca, I think we couldn't have a better conclusion because with your 3 points you were very clear and I think that you were able to represent all of us. And I loved how the way you underlined how important is the community-based approach. No, that is really related to another important factor that was underlined by Xenia during her presentation about the importance of training and training the family doctors in finding the first signals of stress and this is one of the most important way to address and give a concrete response in vulnerable settings. So because I think we are run of time, we have a duty of care and we have a duty of care also of our audience, of their well-being. I want to thank all of you for your contribution, those who contributed online, and thank you for your participation. Thank you very much.
Ladies and gentlemen, a buffet lunch is about to be served in Ballivi Room. Enjoy it. The sessions will start at 2 o'clock sharp. Thank you. Ladies and gentlemen, next session will start shortly. Please take your seats. Speakers are invited to join the stage. Thank you.
Vous parlez français aussi? C'était intéressant ce matin. Absolutely. The COVID had a positive impact on putting it higher on the agenda, so it's a little bit paradoxical.
Cada vez. Gorachi, Lanka, και όλο αυτό το... People are not very... It's always succeed. It's not bad that they like to talk to each other, but there's a program. Yeah. Yeah, and the organization. Maybe my Flemish background, but I'm a little bit sensitive for it. Αλλαγή πρακτικά σωλάνε, με χαστία τώρα, είστε τεράσιο. Τίποτα, είναι χάρη μαύρα. Δεν μπορείς.
We have like the frontier, so we have like the northern part, it's more like German, Dutch, and Scandinavian thinking, like I'm a Flemish, and then you have like the Walloon part, French-speaking part, it's already more Mediterranean. This gives also a lot of political... Yeah, there's a cultural and political divide through... You see it everywhere. Flanders has the labor market of the northern countries.
Ladies and gentlemen, panel 3 is going to start. Please take your seats. No, no, let...
Να σου εγώ τώρα, γιατί θα
Ladies and gentlemen, please welcome Mrs. Lydia Lazari, Regional Advisor, Mental Health at the World Health Organization, Europe.
Thank you, and a very warm welcome to everybody. I think it is always tough to be there after people have had their lunch, but I hope our panel will be interesting enough for everybody to come here running. So I was introduced as the Regional Advisor for Mental Health in Europe. And in addition to that, I'd like to start by extending very, very warm thanks to the government of Italy for hosting this event, but also for the tremendous efforts that have been made in Italy to move ahead the mental health agenda and that have made Italy a beacon of mental health in Europe, but also in the world. I would like to share with you the fact that myself, as a young psychiatrist, had the shock of my life when more than 20 years ago I visited Trieste in a study visit with few more mental health colleagues, and it was an eye-opener to see how the democratic psychiatry, as they call it in Trieste, works, and how indeed it is possible to perform deinstitutionalization successfully, supported by a variety of mental health, community-based mental health services worldwide. And rest assured, please, that not only did shape my personal road towards better mental health for all, but of many thousands of colleagues from around the world. And for that, another warm thank you to Italy. By being by having had this exposure to the open mental health systems, one clear lesson that you get is that when people living with mental health conditions are in the community, that per se is an anti-stigma action. And why this is important to notice is because stigma that is attached to mental health conditions is universal, and it pervades across cultures and contexts in countries everywhere. People living with mental health conditions can experience stigma from families, neighbors, and health professionals, as very eloquently the World Mental Health Report that was introduced earlier by the director Kestel proved. And as we learned from the Lancet Commission on Stigma and Discrimination that was issued only a few days ago, we learned that most people living with mental health conditions believe that stigma is worse than the very symptoms of their condition. And it is a very important statement to recognize, to acknowledge, because it should put us into the mode of acting against stigma and discrimination. Stigma also contributes to the systematic under-resourcing and insufficiency of mental health systems across the world through policy, through financing, through service provision, by thus greatly increasing the risk for human rights violation. Very briefly, what happens in terms of policy? Only about half of WHO member states, only about half of the 193 WHO member states reported full alignment of their mental health policy or plans with international and regional human rights instruments. This is true also for the WHO European region. Moreover, in Europe, only half of our member states have an authority or independent body that at least annually evaluates compliance of health facilities with law and human rights. In terms of financing, we learned from the opening given by the Italian government, our societies are not spending much on mental health. It is only about, mental health spending, it's only about 2% of government health expenditure worldwide. And this is particularly lower in low and middle income countries. In terms of services, we have the predominant use of psychiatric institutes, psychiatric asylums over community mental health systems. And that reinforces the perceived difference between people living with mental health conditions and those who aren't. While in the WHO European region, we have an advantage in mental health resources, just to mention that we are several-fold richer in mental health resources than the rest of the world, and still in Europe, we continue to have an important treatment gap. We continue to have very low demand for mental health care, because this can be driven by low levels of health literacy. So what do we know about mental health? Including a lack of knowledge and understanding of mental health, as well as a predominance of prevailing beliefs and attitudes that undermine the value placed on mental health and effective mental health care. In many communities, as many of you know very well, mental health conditions are not considered health issues. They are seen as a weakness of character, as a punishment for immoral behavior, or as the result of illicit drug taking or supernatural forces. In all cases, the media can exacerbate misconceptions by portraying people with mental health conditions as dangerous, as irresponsible, or as incapable of making rational decisions. And with this, I would like to close this address by saying the greatest cost of low and poorly allocated resources, of lack of policy implementation, and of inadequate and inappropriate mental health services leads to human rights violation. On this and more, I am honored to be joined today by a distinguished panel of a variety of representatives of member states, people with lived experience, policymakers, and so on. So without further ado, I'm going to my chair, and the format of this hour will be that there will be 2 rounds of questions that will be asked to each panelist. But first and foremost, I have the honor to announce the special advisor to the Minister of Health of Italy, Ms. Sandra Zampa, that will give us a recorded intervention. She unfortunately could not be with us today, so she excuses herself, but is with us through this intervention, which I'm inviting all to watch. Thank you.
Ordinaria nella storia
in Italian history. The law was approved in 1978 in a highly innovative climate where there was much innovation and in the years around 1978, healthcare service was involved, and there was also cultural reflection on what we refer to as social health. Basaglia fought to close psychiatric hospitals. There was a movement of healthcare providers, citizens, politicians who supported the adoption of this law, and this law made a country a cutting-edge country in this respect. Quality of life is recognized as part of the therapeutic path, and this is a great innovation that we are still measuring, and their ability to be, their inclusion ability is also supported. This is the point to claim and to implement theoretical claim, that is the persons do not represent their disease. A person is not his or her disease, and they maintain their dignity and their value in any situation, not only, but for each of these persons, there might be a possibility, an opportunity of inclusion, of being integrated, and an opportunity for a better life for individuals and society. A society that is able to include and a society that is healthier and a more peaceful society. It's a society where there is a place for all, and everyone will find a place, their own place of well-being and acceptance. Therefore, we have all learned much from this Basaglia law. That is, the person is not his or her disease. Everybody's entitled to know their potential. And with this law, we started a path and we'll never go backward. So we are moving forward, but this is a path that is still to be completed. Obviously, innovators, this is a destiny, a fate of innovators, not to see the path that they have initiated being completed. Therefore, we can work together, we can integrate, we must make our way with fear of what is different. Mankind knew the disastrous consequences of stigma when stigma is associated with religious, political, ethnical reasons. There were tragedies in the world and mankind, but the stigma associated with mental health is even more dangerous because it brings people to not to ask for help, so they tend to hide. They do not ask people who surround them, family members, friends, healthcare providers, specialists. They're afraid of seeking help, and in this case, the stigma is dramatically negative. In my experience at the Health Ministry, I had a chance to meet family associations of families with young people who committed suicide. And we feel that these young people did not feel strong enough or free enough to reveal, to unveil their malaise, the depth of their malaise. So that was additional proof of this. Certainly stigma cannot be treated or cannot be fought only by institutions, and we have to fight the stigma at all levels. A cultural change has to be made. Media, social media play a very important role. We know that by creating a stigma in social media, irreversible damage is caused to people, especially youngest people, and it's very important that the whole society fights this terrible plight that is a stigma in mental health.
Thank you to Ms. Zampa for a very, very comprehensive and passionate address to us all. She reminded us of the importance of legislative frameworks. She reminded us about the importance of policy frameworks, but also she gave a very personal touch when she recounted about her own encounters with people who live with mental health conditions. I have now the pleasure to introduce our next panelist, who is Jana Pamfilova, who made her way to Rome all the way from Ukraine. Jana is here because she will tell a bit more about her first-hand experience with stigma and discrimination. But just to start on a positive note, Jana is the co-founder and chairwoman of Teenergizers Ukraine, that is a youth organization built up for the purposes that we'll hear more now. Now, Jana, in your experience, how do you think stigma and discrimination affect people when asking or if asking for support?
Thank you so much, and I'm so happy to be here. My name is Jana, I'm 24 years old, and I was born with HIV. Until February 24, I thought that growing up with HIV was the biggest challenge I would ever face, but I was wrong. This Monday, I was in Kiev and started to celebrate this important day, the World Mental Health Day. But Russian bombing came during this Monday more than 5 hours, and with my friends, with all Ukrainians, we stay in the shelters and just believe in God and that think that we are safe. And also in this day, in Kiev, the Russians killed at least 20 people and 80 people, like 100, more than 80 people. And also attacking across Ukraine. So more than 7 months, Russian invasion of Ukraine has turned lives upside down for millions of young Ukrainians, especially young women and children. You have all read the statistics. Over 12 million Ukrainians have fled their homes since the start of the war. Today, an entire generation of my friends, our peer counselors, our women, students, and children have fled their cities, homes, villages, and studies, and members of our families. We are not statistics, they're tragic story of the desperation and depression of behind each refugee and internally displaced person. And we wondering what will be left of our families and our homes when we return. And millions more, mostly young men, are still in Ukraine defending our city in our homes against for a Russian army that is raping and killing but still has not even declared war. Our men and women protected our homelands and our homeland from Russian bombs and bullets that are costing us our lives, our safety, and threatening our freedom. The Russian soldiers with their destructive landmines and discrete bomb attacks are so much more deadly than any invisible virus like HIV or COVID. Today, I'm in Berlin, and thank you for the German government to accept me and accept a lot of people, Ukrainian people from Ukraine. And we also happy to see how the European country to help us. But thousands of young people under foreign occupation in Mariupol, Kherson, Zaporizhia, or martyred in Irpin, Bucha, Chernihiv, and other cities, they have not been so lucky. I'm a founder of Teenagizer, the last youth network for adolescent young people in Eastern Europe, Central Asia. And I hope other young people never experience the toxic cocktail of anxiety, risk, and isolation that we are facing today in Ukraine. The challenges young people, and especially in adolescents, faced in Ukraine: homesickness, loss of relatives, forced separation from friends, rapes, post-trauma stress disorders, and other mental health illnesses, sexual and gender-based violence, limited access to services for health, reproductive health and rights, and human rights also. I have never been give up, but this war has given me a solidarity with young people in Palestine, Yemen, and Afghanistan, and young people living through conflicts that dragged on longer than the war in Ukraine. For young people facing the combination of challenges, like young people living with HIV or other chronic condition in Europe and Eastern Europe, it's even more complex. It's over 40 years since the first case of AIDS were diagnosed, but society still fears people like me living with HIV. Every year, young people with HIV are still dying, not from the virus, but from the fears and social stigma and an anxiety created by discriminations. Sometimes it feels safer to hide in the shadows with HIV or hepatitis, or even being a gay or being a migrant, then it's come to forward and ask for help when you fears you are going to be treated as a second-class citizen. We spent years fighting so that young people, and especially adolescents living with HIV, could have our health and rights protected, and now it feels our gains have disappeared overnight. Even during this war, we continue to provide online peer counseling, and now we have more than 150 peer counselors who every day support every teenager and young people in Ukraine and out of Ukraine. And I'm proud of our work, but our model is based on volunteer, and we can only support only 10,000. It's small numbers, and we can only and small number of millions of young people who need help now. Who is supporting the numbers of thousands of young people we can't even reach? I'm grateful for many of the international partners who are working around the clock to help the people of Ukraine survive this war. And WHO and government of Italy are giving a platform to young people like me to tell our stories. But even after this war is over, young people in Ukraine will be suffering with the mental scares of these conflicts for years to come. After this crisis, we must ensure young people have access to professional mental health services, especially peer-to-peer. I would like to end my speech reminding you that this war was not started by young people, but our lives are hanging in the balance, and I'm counting on every one of us to show the strength of solidarity that is moment in history demands. Thank you, and Slava Ukraini.
Thank you very much, Jana, for this very eloquent account of your own experience, but also the experience of your peers with both the recent war, but also with the pervasive and systematic stigma and discrimination that you and people living with similar conditions have encountered. There are so many lessons that are there in your brief intervention that I would like to dissect for the benefit of the audience, but I hope that this can, if we have some more time later in this session, we can go back to that. Thank you, Jana. I'd now go to introduce to the audience Stelios Kibouropoulos, who is a member of the European Parliament and a member of the group of the European Parliament for mental health. For those who do not know, Stelios is also a psychiatrist, so he has, in a way, a 360 view around mental health, both as a person, as a professional, but also as a policymaker. Which is why I would like to ask Stelios about what can you tell us on your encounters with stigma and discrimination from all those positions that you feel in your life?
Thank you. First, thank you very much, Dr. Lazzeri, for your kind words. And also I would like to say that I'm very glad that I am in this group, in a very high level, in this high level event. I'm very glad and honored that I have been invited to be part among distinguished members around the world and other guests. And yes, it is true that I have the privilege to see the issue of stigma and discrimination from different perspectives. First of all, as a person, in my life I have felt both the stigma and discrimination from a different perspective to that associated with mental health. But both these two concepts always have a negative perception, regardless of the content. The stigma was there because I was physically different from others, while the discrimination was experienced because the society I lived in as a teenager, among other things, could not accept that I could also excel and become one of the best students among my peers. However, this behavior was not the fault of society itself. That is how it has been structured. That is how we have been taught not to accept different behaviors and functions, and thus we shift the problem to the individual and not the way it has been structured. Only through information and awareness and discussions with others who have had similar impairments to mine did I understand that the problem is not with me, but with society. And thus, the self-determination is a solution. Answering as a psychiatrist, I saw people lose the meaning in their lives because of stigma and discrimination. Because social acceptance is very important for our self-esteem. When we feel useful, this gives us emotional security and help us develop new social relationships. When we don't feel useful, then we blame ourselves and usually avoid social relationships. So we see how such a small word as a stigma can change the social coping, self-perception, and finally, the whole path of a person's life. Finally, seeing the issue from the perspective of politician, as a member of European Parliament, I know that as policymakers, we have to try to eliminate the stigma. Today, apart from the information campaigns, we do manage to talk about horizontal policies. Policies that give people with mental illness the opportunity for a full and dignified life. This fact makes me very optimistic for the future. And I'm very glad to be part of this optimistic future. Thank you very much again, dear Dr. Lazzari.
Thank you again.
Grazie. La sua continua presenza proprio in questi seminari e conferenze che noi facciamo e che effettivamente ci dimostra che effettivamente tutte le persone, se sono sostenute dalla società, possono diventare appunto dei membri a pieno titolo e testimoniare cose molto importanti. E abbiamo qui adesso il rappresentante della Lituania, si occupa proprio di problematiche mentali. La Lituania adesso sta sviluppando proprio un piano di azione che è una delle priorità fondamentali di questa campagna antistigma. Quindi se potesse condividere con noi quelle che sono le misure che voi state in qualche modo attivando per affrontare queste problematiche e anche le problematiche, le sfide da affrontare. Grazie. Grazie per questa domanda molto pratica, pragmatica. Noi abbiamo avviato molto di recente.
My campaign consists of 4 interrelated elements. So first we had to make some preparatory work to reduce the legal or structural stigma. In particular, we have significantly reviewed the limitations that the state puts on people with mental health conditions for the regulated professions, like the medicine, the law, the statutory services, or also what is one of the most used license for driving, or also for holding guns. So we had a lot of discussions around these topics with the experts, and of course we did consider genuine safety and security concerns, but we have seen that very often the limitations on those people are put based on the wrong assumptions about those people being dangerous or incompetent or unpredictable. So we had to challenge that in the discussions, and we had to change that. So this took quite some time, but we're successful, and I think it was necessary to do this because actually, honestly, I wouldn't be able to tell people to open up or seek help if I knew that because of that they could face very serious legal repercussions later in their life. So after this preparatory work, we are now developing a long-term anti-stigma awareness campaign, which consists of mass media communication, of a mental health ambassadors program, and mental health literacy trainings. In order to make sure that all of those programs are targeted for the right target populations, we already made a population survey based on validated international instruments that really allows us to target the measures for very particular and specific target groups and achieve an effect. So currently we're in the process of developing the Mental Health Ambassadors Program, which allows for people with lived experience to share their voice and their story in their local communities in a safe way and reduce stigma in this respect. So we couldn't do that all properly without the support of our international partners. So I'm now talking specifically about the UK, which has a Time to Change program, and its leaders have helped us a lot in establishing this program. But we also have a very excellent report has now been launched recently by the Lancet Commission on reducing, ending stigma. That is really a good report to not to repeat the past mistakes and to design an effective program in this area. So in terms of the challenges that we face, we see that currently we don't have a very good understanding of the main concepts and language of mental health and stigma, and it is very difficult to talk about that in public. So for example, we have some really well-intentioned journalists or authority figures or politicians who are trying to talk about this issue, but they often still use stigmatizing concepts or visuals, and thus they hinder the common effort. So we're still working on that. And lastly, the issue that I think we will face is to ensure a consistent and long-term effort in this area, because actually reducing stigma is a movement that acquires results over time. And if you're consistent, you can see the results, but it will be quite a bumpy road ahead. But I believe that with the help of our partners and a strong team, we can all make it.
Thank you, Ignas. It's very important what you mentioned about the hiccups of the legislation that might hamper the efforts of people to either look for services or to be helped. And also you mentioned the importance of evidence building. You said that you are conducting an assessment yourselves. And last but not least, we're delighted as WHO to have you hosting us into implementing the quality rights tool, which is indeed the way forward to address a lot of issues in mental health, including stigma. We're now going to the next speaker, Nikolai Negai. He is a psychiatrist from Kazakhstan, but he's not here simply because he's a psychiatrist. He's here because he's a fierce mental health advocate from his country. And one of the first things that he brought when we first contacted each other was, how can we make sure that we address stigma in this part of the world where I am? So, Nikolai, how have you seen stigma affect individual lives as a leader of mental health in your country?
Thank you so much, Lydia, for your question. In recent years, there have been revolutionary changes in the therapy and rehabilitation of people with mental disorders. It seemed that this should have radically changed the attitude towards these people. However, psychiatric diagnosis very often becomes a more urgent problem than the disease itself. In essence, the beginning of a mental disorder and the establishment on the fact of its presence is perceived by a person as a sign of an unknown rebirth. Perhaps this is felt more acutely in some countries, including ours, but the manifestations are likely very similar everywhere. And here, in practice, we see two components that, of course, are inextricably linked to each other, a response to a mental disorder and a change social status. When experiencing their guilt in connection with insolvency, they underestimate the requirements of themselves, quit their jobs, drop out of school, and as an extreme form, a limited and narrow circle of communication. When a person cannot accept a mental disorder, he is not inclined to be treated take medications or visit specialists, which leads to progredience and frequent exacerbations of the disease. In some cases, an individual is subject to opinion of others that they should be only among the sick, and he closes down and restricts social activity. In essence, there are options for psychological protection which are combined in different ways. Unfortunately, these strategies underlying self-stigmatization are destructive. The danger is that it masks from patients his true problem, directing his effort on the wrong path. Thank you.
Thank you. Thank you, Nikolai. I picked up one particular moment that you said that when someone is diagnosed with a mental disorder, their social status is changed. And this is, of course, at the roots of attitudes and beliefs and lack of help-seeking behavior, because if your social status changes when you have tried hard all your life to achieve, to go somewhere, then, of course, you don't want your social status to change, and therefore you don't ask for help. Next is the person on my left, Pedro Facon. Is the Deputy CEO of Belgian National Institute for Health and Disability Insurance. Pedro is not a mental health professional, and Pedro is here because during the COVID-19 response of the Belgian government response to COVID-19, Pedro was the head of that response. And during that, you were not shy, Pedro, to sharing with the public your own experiences of stress and burnout. And in sharing these experiences, did you encounter or become aware of stigmatization and discrimination towards people who live with mental health conditions?
Most certainly, and the paradox was that with the crisis teams we worked with, I invested a lot in mental health capacity. They were contacted and accompanied to manage their stress. And at a certain moment I was the victim of it myself. And what was for me quite difficult was, of course, that I was a very public figure in the Belgian politics and media, and then suddenly I disappeared, and there was a lot of also people who tried to diagnose me, and that's one of the problems I have too. In the end, people said he has a burnout. In fact, I had severe exhaustion on physical and mental level. I had problems with anxiety, but then you read in the newspaper one morning that you have a burnout, so you get also a sort of etiquette on you. What a problem with US, and that also means that people say, well, he has a burnout, he won't come back in the next few 3 months, 4 months, 5 months, and in fact it's kind of determinating. So I was confronted with it quite severely. I didn't react to it. When I went out, I put a hat on my head to not be recognized by people. But then afterwards, when I came back after 6 weeks, I got a lot of help from my general practitioner and also a clinical psychologist. I came back, I restarted, and I even felt stronger than before when I started the crisis management. Then I hesitated a little bit. Do I want to talk still about this experience? Because I don't want to be the person walking around all the time, oh, he's the guy who had that burnout. I have had a career of 20 years now in public management and politics, and honestly, it's not the kind of predicate I want to have stick to me. So then I hesitated a lot, but then in the end I said to myself, if in my position as a COVID government commissioner, and now I'm back in public management in the health sector, if even I am not able to share my experiences, how can I expect to break the stigma? So I gave a few interviews. I was very selective on it. I did 2 interviews on it. Got so many reactions on it, very positive reactions of politicians, public managers, people from the work field, who suddenly came to me and said, I have never said this to anyone publicly, but I want to share this experience with you. And then I knew that, in fact, my testimony also helped a little bit for others. And that's also the reason why I came to Rome, to say that it's not because you had a hiccup in your life at a certain moment for a few weeks or for a few months that you will be determined for the rest of your life to be a walking mental case. We are just people. We have some problems. It goes up, it goes down. That's life. And we need to be able to talk about it, to accept it, and to be able to also see that a person doesn't lose suddenly all its competencies, all his or her competencies, because he's ill. We do not do the same with physical illness, so we shouldn't do the same with mental illness.
Incredible. If Pedro, during his leadership of COVID-19 response from Belgium, had broken a leg in one of his visits to a region of Belgium, you would have garnered so much sympathy. No one would have tried to label you as the person who broke their leg in the course of their duty. But then when, in the course of your duty, you developed a mental health condition, everybody rushed into making a diagnosis, making assumptions, deciding on what you have or what you don't. And this is the reality of many people who live with a mental health condition. And on behalf of many, including mental health professionals, policymakers, but also people with, who live with mental health conditions, thank you for making it a theme. Thank you for opening up and reminding everybody how important it is to talk and how important it is to de-demonize mental health conditions. With this, the first round of the questions in this panel is over. We heard a lot, starting from Jana, who told us a bit how people die because of stigma. We heard from Ignas, who reminded us of the hiccups in the legislation. We heard from Stelios, who reminded us about stigma is one, regardless of what condition you are living with. Stigma is stigma, and its very end is that you are excluded and discriminated against. And we heard from Nikolai about the change of social status, and we heard finally from Pedro how mental health stigma is particularly isolating and it leads to discrimination. With your permission, we go to the next round. We only have 12 minutes left, so if I can invite the participants, the panelists, to give very short answers to the second questions. So I'm going to Jana. Jana, you talked, you shared with us a lot the efforts you're doing as Teenergizer to react and to act amidst the crisis that Ukraine is undergoing because of the war. And then how you make sure that in your work as Teenergizer, you have a human rights, very secure human rights approach in your work with young people, and what matters most for empowerment?
Thank you so much for this question. I will be very short. I think that why we have in HIV spheres really great result, because a lot of investment, because the community lead, the government, the society, and scientists, and a lot of donors there. That's why the result is really great. In Ukraine, the drop up of the deaths of AIDS, it's 75%. And I think it should be the same like in mental health. And I think it should be a lot of investment should be in mental health. And what I see, young people, unfortunately, and especially adolescents, they are not in this circle on the political level to talk, to share their stories, and also what will be held and what will be care about our people in Ukraine after this war, and how we can build this program on mental health So it's a lot of questions. So the first, what I would say, we should build the strong community. Second, we should build the strong system on mental health. With international partners, with WHO, with human rights, with civil society, you know, like, and the second one, of course, we should use the practical way. For example, for adolescents, it's easy to talk with the peers. That's why teenagers create peer-to-peer consultation, where we have 150 peer counselors who providing online peer counseling. They're not like providing some psychological consultations, for example, suicide, because it's really hard, and we can set these teenagers to go another place, like more institution, who much more professional, because we care about these teenagers, and we want to save this quality of this service. And of course, if we work with young people, we should use the online technique, online sphere, because all the teenagers and young people in online, and we all have phones, so we should use this. So we should think different and to use the new technology in our spheres. And the last one, we should work with ministries to create and build very friendly services, because we know how it's hard to be with a mental health problem, and how people with mental disorders are very shameful and very afraid to ask about the help. So we should think, and we should create and build this very friendly service for these people. Thank you.
Thank you, Jana. I think if I try to summarize what you said in 2 words, is co-production. What you want, what you call, is for young people to be involved into policy making, to be involved into service delivery, into planning and organization.
Yes, and the last one, age barrier, because many teenagers unfortunately can go to the clinic without parents and ask for the help. Unfortunately, they only need to accept by parents.
You made it very clear that you think that adolescents need peer support, and innovation should be age appropriate. So your point is very well taken. My next in line is again Stelios Kibouropoulos. What do you think are the key secrets or ingredients for success when it comes to promoting human rights in mental health systems?
I think that our main goal should be to decriminalize mental illness in the minds of people. A mental disorder can affect any of us at any stage of our lives, and I totally agree with Mr. Franco that degrees can affect everybody. That does not mean that any of us has a weak character, is an incompetent worker, or is a dangerous person. This is what life is all about, a life that is not as ideal as often presented in the media. This perception can only be changed through the provision of responsible information, and even from the school years. A second objective concerns the correct management of financial investments in mental health. Due to the increased demand for mental health services, the number of facilities in the community needs to increase. A third very important component has to do with self-representation. It is important for people with mental illness and their families to make decisions about what directly affects them, from choosing the right treatment to participating in work education, and family life. These people should be considered the experts, about their own needs and their lives. And finally, let's not forget that patients' rights do not end in ensuring appropriate and dignified treatment. Every patient has the right to participate in every aspect of his work, education, family, and social life. I think these are the three main components that we can success in order to overcome the obstacles in mental health.
Thank you. And your 3 points, including decriminalization of mental illness, financial investments, and respecting the agency of people living with mental health conditions into making decisions about their life are well noted, and I think are well accepted and integrated into the work of many in this room. Ignas, while you work in Lithuania for implementing a human rights-based approach, you are now about to embark on a joint effort between the Ministry of Health and Ministry of Social Care to ensure that both mental health but also social care institutions offer such an approach. How do you think that these efforts will contribute to improving the quality of care in your country?
Thank you for the question. So our effort is squarely based on the WHO Quality Rights Initiative that you mentioned before, and it is an excellent tool to improve mental health service quality and human rights. So from the policymakers' perspective, where I come from, we have a struggle to understand and improve quality of the services, because in that sense it's like a black box. So basically what we see is the number of the services provided, maybe how much they cost, but we don't actually see from the ministry, from the information we get, what kind of services are they? What is in the relationship between the patient, the institution, and the specialist? What happens there? And I think quality rights here gives a very excellent framework to measure and understand and define this important aspect of quality. And in Lithuania, we're also now have implemented a pilot project in this area and now have trained a new generation of evaluators and experts for quality rights, including several people with lived experience who will also go to the institutions and see from their perspective how services look like and how they should be improved. So it's not enough to evaluate actually the institutions, but you also have to provide continuous support and consultations. So this is also part of our model, and also do some monitoring. But here it's very important for us, in a cultural sense, it should not be a punishment-based system. You should not have any performance indicators or targets for this thing, because actually this is an attitude and cultural change, and we found that you only can facilitate genuine change in culture if you go along with the sentiment and with the support of the specialists, the institutions, and the stakeholders themselves. So that's what we're trying to do. But on the other hand, in the mental health reform, service reform that we're now doing, we have made a human rights, a recovery approach, and the reduction of coercive measures at the core of all our efforts. And I think that makes sense because when you see from the perspective of the patient, there can be no quality without human rights. So a patient can only recover and thrive when he or she feels listened to, feels respected, when they can build trusting relationships, and when their hopes and needs are addressed and facilitated. So this is an inexplicable part of quality of the services. So I think that more and more specialists in Lithuania understand that we have to go towards human rights-based approach in mental health. Of course, this is, again, a long road in terms of the cultural change, but the result, I hope, will be the services that are much more acceptable, much more respectful for human rights, equitable, and also effective for everyone.
Thank you. Thank you, Ignace. If I can pick up from what you said, a very important point that improving quality and respecting human rights should not result into punishment, because this is a disincentive. No one then would strive for improving things if they feel that this will be followed by punishments at the service level. It should be indeed a proactive and creating a positive environment where everybody strives for improvement. Nikolai, we talk about individual stigma and then we talk about structural stigma. How do you think that we can tackle structural stigma?
Thank you for the question. Individual stigma is a series of prohibitions associated with a social activity, which leads to social maladaptation. At the same time, changes in the behavior of the close environment are often observed, which by their actions often increase the manifestation of social isolation. Of course, society itself does not perceive a person directly as a person, but perceive him through the filter of its understanding of a mental disorder. And in fact, public opinion is aimed at controlling all deviant members, encouraging their submission and lack of will. As a result, the opinion is cultivated about the need for social discrimination, restriction of autonomy, and freedom of persons with mental disorders. The media crystallize a preconceived opinion about patients as dangerous and incurable patients. This leads to the speculation of concepts in the field of mental health at the social and state levels, forming the idea of the mentally ill is alien to the normal world. And it becomes clear that the stigma, in this case, is already a social attitude, and therefore it will necessarily be permeated by power relations, and accordingly transform it into a structural stigma. In my opinion, one of the key success factors is a systematic approach with a simultaneous impact on the entire social ecosystem of the patient's relationships. What attempt they will have in Kazakhstan? First, transformation of the psychiatric service into a mental health support. Secondly, changes in legislation. Third, raising evidence about mental health. I also would like to note that in the first year of the project, even with a high risk of suicidal behavior, more than 11% categorically refused help. A year later, it was already 5%, and in the third year was only 1%. Next, programs to reduce self-stigmatization and stigmatization in relatives. In the beginning, many relatives and patients refused to participate and work in the School of Mental Health. For example, there were only 10 to 15 people in Almaty. But the pandemic opened up opportunities for online entry into the program, and in a short period in Almaty, the number of participants reached more than 200 people. Having been in the program, as they already come offline. And the last one, activities outside the healthcare sector. It should be noted that the activities that affect the process of destigmatization are very complex. They are difficult to assess, and as a rule, the result of those activities will only be in the future. And today in Kazakhstan, we have not achieved the desired result. But I think we have already come a long way. Thank you.
Thank you. Thank you for your honesty in admitting that you have not achieved the desired results, because it's important that we are openly accepting what doesn't work so that we can then jump into what works. So thank you, Nikolai. Last but not least, Pedro. You now, after having been at the helm of the COVID response of the Belgian government, you now lead the National Health Insurance Fund in Belgium. Do you think that stigma can be addressed through equitable financing of mental health services?
I do, and of course we need to act within our competencies at the National Institute, but of course when we see that so little money was dedicated to primary mental health care, that in itself is already reinforcing and reproducing stigma with regard to mental health. So what we did the last few years, last 20 years, in fact, we had a big shift toward community-based mental health care. A lot of hardware networks we created between healthcare and also social care providers. We created some outbreak management teams, mobile teams, liaisons between many sectors, a lot of instruments that we created. We also, a few years ago, we went towards recognition of clinical psychologists as healthcare providers. But in the end, if we really want to have access for patients and for people to mental health care, we need to reinforce that primary health care. And what we are doing now is creating the primary mental health care through reimbursement of sessions with clinical psychologists. These clinical psychologists, and that's important, they do not act solely, they are not islands, they work within the networks we created. So each network, we have about 20 networks in Belgium, each network needs to manage the budgets for primary mental health care and needs to make decisions on where the priorities in the territory of the network are. So we're trying to support the shift towards community-based mental health care, and the insurance, of course, is only one instrument, but I think if we strengthen that primary care, we will also tackle stigma.
Thank you. Thank you very much. You could indeed be a WHO ambassador for promoting integration of mental health into primary health care, because this is indeed one of the tools that securely increase access, improve quality, and by virtue of that, decrease stigma. With this, we'll come to the end of this session. It has been incredibly rich for me, that has been very attentive to everything people said, and I hope for the audience as well. Thank you very much to the organizers, to the Italian Ministry of Health, for giving us the possibility to talk on stigma and human rights. And with this, we close the panel. Thank you.
Ladies and gentlemen, the thematic parallel sessions will start in 10 minutes. Please check your room on the provided map. Thank you.